Good afternoon. I'd like to call today's meeting of the OCA Board to order. Um, I'm pinch hitting today for our chair, Secretary Galley, who is off doing good secretary work somewhere. I don't know exactly where he is. And so he asked me to fill in today, so it'll be my honor to do that. Now what I'd like to do, recognize, of course, that we are recording the meeting. And we'll now move to roll call.
Thank you. Secretary Dr. Mark Galley. Dr. David Carlisle.
Present.
Dr. Sandra Hernandez.
Present.
Richard Kroenig.
Present.
Ian Lewis.
Present.
Elizabeth Mitchell.
I understand she's in the house and will join us momentarily.
Yeah.
Dr. Richard Pan.
Present.
Don Molds. And Elizabeth Mitchell.
Great. With that, we will establish that we have a quorum to proceed. So with that, I will give it over to Director Landsberg.
Thank you very much, Dr. Hernandez. Good afternoon, everyone. Welcome to the Office of Healthcare Affordability's Affordability Board meeting. Pleased to have you with us today. And I'm just going to start by going over today's agenda. So after executive updates from Vishal Pagani and myself, we have the one action item is just to go over our minutes. I'd like to note, as Dr. Hernandez did, that we do have a few substitutions, so very much thank Sandra Hernandez for stepping in. Dr. Galley is actually in New York at the United Nations talking about behavioral health with the governor. So yes, so we appreciate Dr. Hernandez stepping in. And we also have Sheila Tatayan out today, so appreciate that we'll have Assistant Chief Counsel Brian Kearns covering our cost and market impact review agenda item. So we have, in terms of our informational discussion items, we will be talking on the total healthcare expenditure side, partly about the feedback that we got yesterday from the advisory committee. So we had a very robust discussion with our OCA advisory committee yesterday. So we had an all-day meeting with them, got a lot of feedback, and so appreciate that CJ Howard is going to work to try to encapsulate their comments. Very much appreciate that Dr. Pan was at the meeting all day. The purpose of the advisory committee, of course, is to have a very broad group of stakeholders to give us input to advise the board. And so between CJ Howard and Dr. Pan, you'll get a good sense of the feedback from our advisory committee participants about total healthcare expenditure measurement. We also wanted to give an update to the board about an overview of some decisions that we have made for the baseline report. And then perhaps for the moment some have been waiting for, we'll start talking about the actual measurement for the spending target itself. So appreciate that we'll have some presentations both from staff and from Michael Baylett about potential economic measures we can use for the spending target. We'll again be conveying some of the feedback we got from the advisory committee and then hear where the board is on that. And then last but not least, we'll be talking about the cost and market impact review. So that's a review of the agenda. In terms of executive updates, I'd like to just start by highlighting a report that centers the healthcare affordability conversation on consumer needs and challenges. So like many of you, we're continuing to read the research out there. So in August, the think tank Third Way put out a report noting that middle-income Americans, those earning between $50,000 and $100,000 a year for a family of three, are the most likely group to be saddled with medical debt. And in fact, 1 in 4 of them, roughly 17 million Americans, have unpaid medical bills. And that holds across every demographic category. The report showed that middle-income families are slightly more likely to have medical debt than lower-income families, despite higher rates of insurance coverage, due to the troubling reason that lower-income families often delay or avoid care because of cost. But of course, when they do seek cost, they may qualify for Medicaid. Middle-income families are also less likely than higher-income families to have the disposable income to pay high deductibles and other out-of-pocket costs. So this report continues to highlight the growing and seemingly intractable problem of medical debt and its consequences on our neighbors and fellow Californians, including increased risk of eviction, food insecurity, and negative health outcomes. In terms of HCI departmental updates, we continue to be excited about our HPD, our All-Payer Claims Database. So I've talked about the HPD snapshot that was our first public set of reports. We just earlier this month released the HPD Measures Visualization, which covers 3 measurement categories: health conditions, utilization, and demographics. So on the health condition side, we're quantifying the prevalence of long-term illnesses and major medical events such as diabetes, asthma, and heart failure. So you can search by any of those and many other conditions. On the utilization side, our utilization measures present rates of healthcare system use through visits to emergency departments and different categories of inpatient stays, such as maternity or surgical stays. And then third, the demographic measures describe the health coverage and other characteristics, including age and sex assigned at birth. On the geography side, you can sort by covered California regions or by county. I will note that we don't yet have race ethnicity demographic data, which is a high priority without the level of reporting we would want at this point, and we're pushing our partners to improve the reporting there, but regardless, we will start reporting that in 2024. At the upcoming October HPD Advisory Committee, we will review the public reports and priorities for public reporting, and we'll discuss non-claims-based payment data collection. So appreciate that OCA and HPD are working together in terms of thinking through how to collect that non-claims data. Moving to our health workforce development work, we have a number of programs currently accepting applications, always critical for us to have our pipeline programs to diversify the health workforce. So we have our Health Professions Pathways program, which includes pipeline initiatives, summer internships, postgraduate fellowships, and post-bac scholarships. Also have a new justice and system-involved youth behavioral health pipeline program, which we're very excited about, and many scholarship programs accepting applications for our allied health programs and several of our nursing programs. So help us get the word out. And then I've talked at previous meetings about our implementation of the Distressed Hospital Loan Program, and I'm pleased that in August we announced $300 million in distressed hospital loan awards offered to 17 different hospitals. Our partner, CHAFA, the California Health Facilities Financing Authority, sent letters of commitment to those loan recipients. And our HCI team is now shifting its focus to the development of potential loan modification and loan forgiveness criteria, which is outlined in the legislation. So that is some of what we have been busy doing here at HCI on the department side. With that, I'm pleased to turn it over to Vishal Pagani.
Thank you, Director Landsberg. So as we do at every meeting, I'd like to remind the board about our slide formatting key. As you all know, the statute denotes different roles for the board in different areas. We use a yellow arrow in the presentation for areas over which OCA has decision-making authority. It's important for OCA to get stakeholder input on these areas, and these meetings are an important way to engage with both the board and members of the public. For areas where the board has ultimate decision-making authority, we note it with the green arrow. And I'll now turn it back over to the chair.
Great. I think we'd like to take public comment on our director and deputy director's remarks. Are there anybody in the room that would like to comment on that?
All right. At this time, we'll now open the room up for public comment. For individuals in the room, you can step to the podium. For the individuals online, please raise your hand and we will unmute you. If you're dialing in, please press *5. Noting for the record that we have an estimated 70 individuals attending virtually, but seeing no hands raised at this moment. And in the room, seeing no one stepping forward to the podium. That concludes public comment.
Great. So then with that, let me turn it back over to Deputy Director Pagani so we can consider the minutes.
We just have the June meeting minutes. The meeting minutes have been distributed and include written public comments received since the August meeting.
Can I get a motion from the board?
So moved.
Is there a second?
So a correction for the record, apologies. I believe it's the August meeting minutes that are being reviewed.
Yeah, it was a typo on my end. Yeah,
Apologies.
the August meeting minutes, sorry.
I'll accept the motion in a second. Great. Open it up for public comment on the minutes.
All right, at this time, we'll open for public comment on the August 22nd board meeting minutes. Looking to the room, seeing no one step into the podium, looking online, seeing no hands raised. That concludes public comment. Thank you.
Great. There's a motion on the floor to approve the minutes. Let's do roll call.
Secretary Dr. Galley. David Carlisle.
Aye.
Sandra Hernandez.
I abstain. I wasn't at that meeting.
Richard Kroenig.
Aye.
Ian Lewis.
Aye.
Elizabeth Mitchell.
Aye.
And Dr. Richard Pan.
Aye.
Motion passes. Anything else from the board on the minutes or the previous items? Okay, if not, we will move on to Deputy Director Pagani.
Thank you, Chair. So I'll be covering over our plan for item 4 related to total healthcare expenditure measurement, including advisory committee feedback from the September meeting that occurred yesterday, and some of the draft decisions we'll be discussing, as well as the spending target methodology considerations. I do want to note that before we dive in, we do have 3 distinct topics. The first is advisory committee feedback. The second is draft decisions for the baseline report. And the third is spending target methodology. I'd encourage us to spend the bulk of our time on the last item, which is the spending target methodology. So we've set aside about an hour and a half to cover that, but that requires that we don't get slowed down too early on the first 2 items. So I'm going to ask our facilitator to note when we're at 20 minutes for each of these items, and we'll take stock at where we're at in the discussion and proceed along. So as you all know, the advisory committee met just yesterday, so I wanted to start off with some of their feedback. So what the advisory committee, we essentially have been catching them up on the board's discussions of various topics related to THCE. And the first topic that I wanted to relay feedback from the advisory committee is with respect to risk adjustment. So some members of the advisory committee raised concerns about the age-sex approach for risk adjustment and its predictive power in explaining population risk. Some members also noted that some clinicians may be undercoding, with the benefit occurring to insurance companies who have to pay less for that member's care. Other members noted that an age-sex approach may be suitable for the narrow purpose of OCA's purpose in terms of measuring year-over-year growth for large populations. And then with regard to OCA taking stock of what the advisory committee said, OCA would note that the age-sex approach to risk adjustment would be for the baseline report, and OCA expects to learn a lot from the initial submission of THCE, or total healthcare expenditure data. This approach standardizes an approach to risk adjustment for the initial years of the program. As OCA gains experience, we are open to other approaches that could consider clinical risk adjustment, while balancing the introduction of additional biases in the data due to the variation in diagnostic intensity among healthcare entities. And then the second topic I'll be covering with regard to AC member feedback is attribution of spending to provider entities. Several members acknowledge that for HMO carriers, attributing spending may be more straightforward when there is selection or assignment of a primary care physician. Other members raise flags that attribution approaches could result in scenarios where patients are being attributed to urgent care or emergency departments, which are really not managing the member's care. One member noted that for some patients, the PCP may not be managing the member's care. And they gave an example of a patient that's newly diagnosed with cancer and their care being managed by a specialist oncologist going forward. Other members raised issues with stop loss or reinsurance policies and how that intersects with the way we're going to be collecting spending data. Stop loss or reinsurance policies are purchased by medical groups to cover high dollar expenses for member care. This would mean that the physician organization or medical group would not bear the full expense for expensive care, such as catastrophic care, because the stop loss insurance would cover all expenses above a certain attachment point. The members also noted that reinsurance policies are also purchased at the plan level. So in terms of OCA, reflecting on this feedback, this is an issue that we will look into as part of our engagement with plans and providers. We're aware that when plans capitate medical groups, we'll be capturing that spending as part of THCE. But for now, we won't have a line of sight into the expenses that happen under the capitation, and that's an area of further exploration for OCA. And then I'll be moving on to a topic that's been that has been raised here at the board level as well, which is consumer out-of-pocket spending outside of health coverage. Many members of this board and the advisory committee have remarked on the need to be as comprehensive as we can be in measuring other spending outside of what OCA is defining as THCE. As you all know, THCE is tied to payments for covered benefits under health coverage. In particular, there's great interest in measuring out-of-pocket spending by consumers for mental health or behavioral health care. Just to give you a sense of kind of OCA's reaction to both the board and the advisory committee's feedback on this issue, based on our assessment, there are no comprehensive data sources on annual out-of-pocket behavioral health spending for Californians. And I'm talking about actuals in terms of what people actually pay. But there are potential approaches to estimate the spending. One possibility is to extrapolate estimates from the Medical Expenditures Panel Survey, or MEPS. So we're evaluating ways to estimate this out-of-pocket or out-of-pocket and plan spending for various types of care. Another possibility is to commission survey-based research or incorporate questions into existing surveys, such as the California Health Interview Survey. I do want to caution that even if extrapolated from survey data, the numbers would not represent actual spending, but would be estimates that may include some margin of error. So I do, having said all that, I do want to emphasize that in any narrative of baseline or annual reports that OCA will publish, we certainly will contextualize the scope of what is counted under THCE and remark on the problem of Californians paying for care outside of health coverage. But at this time, we can't commit to estimating these other areas of spending, and particularly on a routine annual basis, when we're continuing to build our staff capacity to meet activities under current law for data collection and progressive enforcement of spending targets. However, as we continue to build up our team, particularly our research and analysis group, we will be developing a broader research and evaluation agenda. Given the anecdotes and some of the painful anecdotes we hear about consumer spending out of pocket for behavioral health, this is an area we can consider for future research. This work could potentially be valuable in evaluating the impact of spending targets and other OCA policy initiatives, such as increasing the proportion of dollars spent on behavioral health and primary care services, for example. So that in a nutshell is some key themes. With respect to the topic of total healthcare expenditures, later on in the agenda, we'll also relay advisory committee feedback on CMIR and the spending targets. But I do want to turn to Dr. Pan if he would like to add anything.
Thank you, Vishal, and appreciate your summary of the advisory committee discussion. A couple things I would just add to that. And so in the discussion about the risk adjustment, age, sex, as you may note, there are several advisory committee members who are concerned about just using that as a sufficient age adjustment, as a sufficient adjustment. I would make note that some of the advisory committee members also said that, part of what we're doing is also building confidence in our methodology and the targets itself. And so they did express that oftentimes what will happen is that if you don't use adjusters, which people expect you to use, that people can see you have people who are, have chronic diseases or other types of conditions, and that if you don't adjust for that, that people often have less confidence, and they're going to say, well, my patients are sicker, or those patients are sicker, or whatever. And so that even, I think there's a communications issue. There's sort of the technical issue that we talked about, how much does it move it and so forth, but there's also a communications confidence issue that's related to the adjusters as well, that people actually feel like you've incorporated and listened to them and incorporated those concerns, and it's something that they see in their, whether patients see that and their families or practices see that, et cetera. So I think that's something that would also need to be addressed in any sort of communications about our adjusters and what adjusters we pick, that we actually, the people feel confident about. We're actually doing the adjustments that people expect us to do to incorporate things that they see in their own, practices or their own lives. I think in terms of, I think there's certainly a desire in the advisory committee, as you said, to try to get at sort of these other sort of out-of-pocket expending. The challenge is that, yes, you're right, there isn't a database with that, but that doesn't mean it's not significant or important, right? An influencer, I think people brought up, for example, how much people spend on essentially alternative medicine, supplements, et cetera. People talked about their FSAs and so forth, other out-of-pocket costs. Actually, workers' comp came up, which I know that we sort of said, well, it seems to be out of scope, but it is a form of health care, so related to workplace injury. So that was raised as well, whether, in terms of trying to figure out how to be sure we're actually capturing and that spending. And then another issue that also, I think you talked about the reinsurance, and then I think talked a bit about in terms of trying to emphasize, I guess, in terms of emphasizing. Oh, there's also some discussion about ERISA plans and being sure we capture those, and I think hopefully we will capture that. So there's the out-of-pocket spending and then the self-insured, and whether we'll pick that up in our plan database and so forth, but that we not. Because I think, as we were talking about, I think I may be bleeding into CMIR. I guess, so, yeah, I know we're going to cover that later, so I may be bleeding over in there. So anyway, as I'm looking through my notes, they're in different order. So, so those are some of the things that the advisory committee remarked on in addition to Vishal's presentation. And thank you so much for presenting. Thank you.
Shaw or Dr. Pan, I'm curious on this issue of consumer out-of-pocket for behavioral health and the lack of a source of reliable data. Was there any recommendation about how we might remedy that situation in terms of capturing that data in some systematic way?
Well, I guess I would say is that the concern was raised, the solution was not proffered. So that's the challenge, right? So how do we capture that? So yeah, I did not recall anyone proposing a solution to that.
Vishal and I have had some conversations about this, and the medical expenditure panel survey conducted by AHRQ, an agency that I used to direct, won't produce a perfect estimate of this. I would quibble a little bit, Vishal, with your characterization that any of these other sources will be estimates. I won't quibble with that, but I will quibble with the implication that our other measures of THCE won't be estimates, that they'll be solid data on what's actually spent. Everything here is estimates. You know, the estimates that come from the insurance companies, from the carriers, may be more precise estimates than what we'll get from MEPS, and likely more precise than adding questions to CHIS or another survey. But I don't think we should kind of fool ourselves that sort of on the one side is data that's really precise with no error, and on the other side, data that's really imprecise with a lot of error. It's always a question of how much error, and you know, I would agree with you that MEPS will produce an estimate with more error than our other measures of what we're going to get from the carriers. You know, whether the amount of error is acceptable or not. I mean, certainly for a baseline report of trying to understand, you know, right now we have no estimate of how much out-of-plan, out-of-pocket spending there is on behavioral health. And I think we would be better served with some estimate, even if imprecise.
Yeah, thank you, Rick. I would clarify that the spending for THCE would be actuals based on claims payments, and I know it. You know, there might be some claims that we miss.
There'll be errors that the carriers introduce in what they do. There'll be stuff missing. I mean, all data have errors in it. Right? You know.
Elizabeth, please.
Thank you. I wanted to sort of support moving forward in any way, however imperfect, on collecting this data. I just think it's critical to understanding affordability. But then on the risk adjustment side, I heard the concern about sort of the reliability of the approach of just using gender and sex, but I think there's also worries about the reliability on the other side, given the sort of steady increase in risk scores that aren't explainable by demographics and disease prevalence, as well as the sort of epidemic of upcoding I think we might be experiencing. So I actually am very supportive of the planned approach. And if things become clearer in the future, maybe we can adjust it. But I think for the purposes of measuring expenditures, I think it's the right way forward.
Dr. Carlo.
You know, I'll just lend my echo to what board member Elizabeth Mitchell just said. I feel exactly the same way. Thank you.
Yeah, Michelle, I guess I would just add, if I could, on this question of kind of the out-of-pocket spend for consumers in behavioral health, that however imperfect an estimate might be, it is such an important part of the way behavioral health gets paid for. And the costs that people pay for that has a wide variation. And so I would encourage us to sort of think about where we might be able to systematically start to get as good an estimate as we can on something that is as important as that. So I would lean into that as best as we can. Other board members? Dr. Pan?
Yeah, myself, not for the reporting on the advisory committee. I think in terms of the risk adjustment, certainly, you know, we've heard about concerns about upcoding and so forth, but I also make note that we also deal with the problem of adverse selection, and that's why people with chronic diseases and mental health conditions oftentimes have harder time finding care and tend to, you know, and people put barriers, sometimes direct or indirect, there, and so people get passed around because they know they're going to be costly on an ongoing basis, not just the 1 year. And so, I don't think we necessarily say just throw out everything because we're worried about upcoding. I think what we do, in the same way that you talk about estimates and so forth, we come up with ways to try to address. If it looks like it's upcoding, then we address that. But clearly, people do have different risks, right? And that's that I think hopefully is not something that's in dispute, and that we know that some people pursue a strategy of avoiding people who have ongoing higher risk ongoing basis, and that's actually a strategy some risk-bearing organizations pursue as a way to to keep their costs down. So we don't want populations essentially, and this becomes an equity issue as well. So I think we walk into it eyes wide open, but I don't think the idea is just to say, well, if someone's going to potentially game the system, people are already gaming it the other way right now, and we have to acknowledge that.
Ian, please.
Yeah, thank you. I guess I'll just add my 2 cents. My own thinking on the question of risk adjustment has changed as a result of the conversations in this room. I've seen the power of it when it's used in a very qualitative manner to assess particular practices and their case mix, but in a much more formulaic and structured and statutory, regulatory framework, I completely concur now, and this is not where I started, that as flawed as they may be, the sex and age-based approach is probably the most reliable that we have in this kind of setting. That's not to say that there isn't very good analysis that can and should be done of different health plans mixes and providers mixes down the road, but that for the purposes of this board's mandate, that the sex and risk and age-based adjustment is the way to go.
I would add only that Dr. Pan, certainly you're right that people vary in their level of risk, and that medical groups vary in the level of risk of the patients that they serve. Some medical groups will be serving sicker patients than others. As you know, and I think what's important to remind people who are concerned about this adjustment is not being used to compare per capita spending across medical groups. It's being used to compare over time the rate of increase in spending. And what I don't think we have any evidence of, and not much reason to think actually occurs, is that the risk for the health status of the patients cared for by a medical group changes differentially over time. I mean, it's certainly possible that it could, and the incentive problems that you raise are worrisome. But on balance, I think responding to that by saying we are going to use clinical risk adjustment raises more problems. We had discussed briefly, and I think it sounds like it's gone by the wayside, the possibility of adjusting for the number of Medicaid patients with disability, which would be a partial way into clinical risk adjustment, but is not gameable by the medical groups, and that might help a little bit, although probably not all that much.
A time check for the record, right? 20 minutes on this topic.
Let's take a couple more comments from the board. Dr. Pan, did you want to weigh in?
So I don't disagree that, for example, we're trying to set a global statewide risk that, or even if we do fairly broad populations, that things don't kind of wash out. Although I would also point out, we're coming out of a pandemic that is leading to much higher rates of disability. So the research on COVID and long COVID, the percentage of people, how we want to reflect that, whether that gets reflected in terms of, well, we have a higher rates of disability in the state, may need, if we're not, maybe something we need to acknowledge. We're talking about mental health disorder, et cetera, but and that's why people are all demanding we need more mental health professionals, we need more. Some of it's because there's concern there's actually even higher demand because of what's happened as a result of this pandemic, which is, of course, a hopefully once in a century event, not something that'll happen more frequently. But I think also as we're having this discussion, it's not, obviously our most immediate is sort of a statewide target, but we are going to start drilling down into like sectors and start getting more narrower. And that's a place where, again, I think some form of risk adjustment is that we walk in eyes wide open, right? We know that but I think if we don't, and I think this is what reflects in the advisory committee discussion, is that people also need to have confidence, right? And so that the excuse doesn't become, well, basically you're ignoring the fact that I'm taking care of a sicker set of patients, and for some people that's actually a legitimate concern, and that they're going to be penalized for that. So now we're going to push people to say, well, if I don't want to get dinged by this board, then I should pursue a avoidance behavior, and I think that in the long run would be harmful.
Okay, Vishon, I think we stayed within our time limit. Do you want to do public comment?
Yeah, just one remark. Thank you all for your input. As I mentioned in my remarks and what Board Member Mitchell stated, this would be kind of our approach for the baseline report, and we're going to continually assess this issue of whether clinical risk adjustment should be introduced. We're certainly open to it, and for at least just for the launch of our program, we think the age-sex approach is the right one, but it's definitely something we'll continue to reassess going forward.
Okay, I recognize that we have a number of members of our advisory committee and of the general public that are here, so maybe we will open this up now for public comment, please.
All right, we will now open the item for public comment. To ensure equitable access to verbal public comment, we will alternate between members of the public present in this room and those attending virtually. Present in this room, please step to the podium. If you're virtual, please raise your hand. Seeing no hands raised at this time, going to the individual at the podium.
Beth Capel on behalf of Health Access California. First, I want to commend Dr. Pan, Director and Deputy Director, for having sat through from 10 to 5 yesterday and doing it again today. So, as I did, it was a long but fruitful day. I would note that it would serve this board better if you had a sense of which advisory committee members made which comments. So the advisory committee members that focused on clinical risk adjustment represented a medical group and a hospital system. And so that's not to diminish their comments, that's just to recognize that they have a particular perspective. And the point of the advisory committee is to collect those perspectives. The other comment that was made by me was that, and I think this board has had presentations on this topic, the equity cuts a different way when you think about access to care for low income and communities of color, that people who are low income and from communities of color do not get as much care, which is wrong, but it is a reality. And so I think as we're balancing the equity and the need, the recognition that older, more affluent, whiter are more likely to have multiple diagnoses is worth remembering. And so it's just another piece for you to consider, since this discussion plainly is not going away. Thank you.
Thank you.
Thank you. Looking online, if you'd like to make public comment, please raise your hand. Noting for the record, we have about 95 individuals. Janice Rocco, I see your hand raised. We will unmute you. You should be able to go ahead.
Thank you, Janice Rocco on behalf of the California Medical Association. I do think that in terms of the risk adjustment issues, it may very well be that the health plans and the providers are very familiar with the use of risk adjustment and why we do that and have been doing that for a long time in the health plan space. We know that if we did not have a risk adjustment system in the individual market, then we would have health plans refusing to sell in the individual market. And with age and gender being the sole determinants for risk adjustment, you can use those, and it may be the case that no one is able to directly correlate those choices with providers feeling like they have to see a smaller group of patients who have high healthcare costs. But from regulating insurers at the Department of Insurance when I worked there, I would say that if an insurer proposed this system, we would consider it a discriminatory plan design that we would know would discourage enrollment of people with greater healthcare needs. And we don't want to put providers in the situation where they're having to make those decisions in order to meet the cost targets. So while I acknowledge that if we go down this path, we may not be able to measure exactly the impact of it, but we will have an impact that is not driving equity, that will be doing the opposite. So I understand the staff have made a decision and some of the board members now have been convinced to go along with it. I hope that this can be revisited in the future.
Thank you very much for the public comment, and I do just want to add a couple of things since this is a decision that's being made by the office. And just to reiterate what Ms. Capel said on the equity side, and I think Michael Baylett showed this slide, but the Massachusetts HPC did a terrific presentation about risk adjustment, in which they used two different mothers who had health conditions, and the single mother who couldn't get time off of work delayed getting care, got sicker, but didn't go in to get her condition diagnosed, and the affluent mother who could take time off of work, who got her condition diagnosed, had the ability to do all of this upcoding. And so I think having that very practical example really illustrated to me some of the problem with the adjustment. And the other piece is the critical one that Rick has talked about, that Vishal and others have articulated, which is, I hear you, Ms. Rocco, on the point about plan design and medical group considerations. And it's different here because it's the same health plan or the same medical group's population and measuring the spending growth target over time. And so we acknowledge, of course, that there will be some changes in a patient population from year to year, but we think it's stable enough that we think we've made a sound decision. So just wanted to share again some of the deliberations that went into this decision.
Okay, continuing public comment. Any additional comment in the room? Please step to the podium. Looking online, seeing no hands raised. No one at the podium. That concludes public comment.
Great, thank you. Michelle, you want to continue? Let's continue. Do you want? Yeah, we should continue. Let's go.
So I'll be covering I'll be giving a summary of OCA's key draft design decisions for total healthcare expenditure measurement. So the next few slides will highlight OCA's tentative decisions on the measurement methodology for the baseline report, summarized according to the four categories listed. The first being spending that is being measured, the second, spending data sources, third, spending analysis, and fourth, characterizing and understanding spending. Next slide. So for this category of spending that is being measured, OCA will measure spending for residents of California, regardless of where they seek care. So what this means is that if there's an out-of-state claim in terms of a member receiving care out of state, the goal is to capture that spending, as well as all the care that they receive within the state. OCA will also measure claims payments, spending for claims. This means all payments to providers for covered services. We'll also measure consumer out-of-pocket spending obligation for all claims for covered services. This would include copays, coinsurance, and deductibles. I do want to note that this is the member obligation to pay based on the benefit design of their health plan, but we will not be able to track what the member actually paid. Next slide. So we'll also be, as part of the THCE, we've shown you the 4 boxes. So non-claim spending is one of them, and the 6 categories are listed here. So, capitation is the largest bucket of spending under non-claims payments. So we have, that 4th bullet shows capitation and full risk payments. But California, given the degree of delegation and non-claims payments here, we have a significant amount of non-claim spending to measure. This will include population health and practice infrastructure payments, various performance incentive payments, shared savings and recoupments, capitation, as I mentioned, and another full or global risk payments. And then we have this other category for anything that, doesn't fit neatly into the others. We'll also be capturing pharmacy rebates. This is kind of more of an adjustment in terms of, we'll get the gross spending on claims, but then we'll have to adjust, with the pharmacy rebate data. So that, in a nutshell, is the high-level categories we'll be collecting, and then I'll be moving on to the next slide for the data sources. So for this first bullet here, OCA will collect aggregate healthcare spending data across all markets from carriers with 40,000 or more enrolled lives in their commercial Medi-Cal or Medicare markets. So we discussed this at the last meeting, this 40,000 or more lives threshold, and how many carriers will be, or how many lives we'll be able to pick up. Just restating that here. Also do want to mention that there is a significant amount of spending that happens outside of Medi-Cal managed care organizations, and we'll be collecting that data from the Department of Healthcare Services. We've been actively coordinating with them as a sibling department on this set of activities. For traditional Medicare, which is paid on a fee-for-service basis, and standalone Part D Medicare Advantage plans, OCA will collect spending data from the Centers for Medicare and Medicaid Services. And then this next category is other spending. So this would be spending that's included in a statewide total. So we likely will include Veterans Affairs, Indian Health Services, correctional healthcare services that are paid for by California Department of Corrections and Rehabilitation. And then we did explore other categories of spending, such as TRICARE, but there are some challenges that prevent us from getting a California-specific figure. So these are the 3 that we're pursuing for now. For insurer administrative costs and profits, we would collect this from federal and state reports when data are available, and from insurers directly, or from financial statements when they are not. So this would be from the CMS Center for Consumer Information and Insurance Oversight, CIO. DMHC would be another possibility. And then the National Association of Insurance Commissioners, we could also get admin costs and profits from the various MLR-related filings that happen, and the same for Medicare Advantage carriers as well. So moving on to the next slide. So, we're going to be collecting all this data, and kind of the next question is, what are we going to do with it in terms of the capabilities for data analysis? So do you want to, we've showed a variation of this figure before based on how other states tend to break it out. This is basically one curated for California based on these tentative design decisions. So at the highest level, we will be able to track per capita healthcare spending on a statewide basis. As many of you have noted, and feedback from the advisory committee and other stakeholders, due to the sheer size and population of California, there's great interest in having a regional breakout. We think this will cover about 25 regions, and CJ Howard, Assistant Deputy Director, will cover the specific regions shortly. We will also be able to break out spending by the different public and private markets, including for Medicaid, Medicare, and commercial. For commercial, I do want to note we have a little note in the italics here, which is including by product type. So we did receive feedback from the advisory committee about, commercial itself may not be maybe too broad of a bucket to report spending performance at the market level. So we will be reporting by product type, which would be HMO capitated products and EPO, exclusive provider organization, or preferred provider organizations, PPO, spending that is paid more on a fee-for-service basis. So that covers the fourth bucket. And for providers, we'll be able to report by specific healthcare entities, as well as for payers, for specific payers. And then lastly, we'll also collect service category spending, and I'll be going over that in more detail on the next slide. So here are the high-level service categories that we aim to collect spending data for. I do want to note that this data is likely to be more populated when there's a claim for each service. We expect PPO products that pay fee-for-service to report more complete data that will enable a service category breakout, while HMO capitated products may be less complete due to the prevalence of non-claims payments. For the category of professional, this is a very aggregated category. So I do want to note that this intersects with other activities of OCA to measure primary care and behavioral health spending. For the baseline report, which will cover calendar years 2022 and 2023, we will capture professional spending on an aggregated basis. And then as we get stakeholder input from work groups, the advisory committee, and the board, OCA will be defining what services count as primary care and behavioral health, including the types of providers and the settings in which they're delivered. So this category professional will be broken out further. For example, professional behavioral health, as an example. And then product types, I mentioned this earlier on the previous slide. We do intend to separately report commercial product types, as well as Medi-Cal managed care. So with that, I want to turn it over to Assistant Deputy Director Howard to cover the remainder of the slides.
Good afternoon. My name is CJ Howard, the Assistant Deputy Director of the Healthcare Spending Targets Branch. Covered the last couple categories of how we're planning to collect the data for our initial and baseline report. So we've discussed here before geography, and I think we went over several different options, and I think we've landed on using the covered California rating regions as the default, except for LA County, where we plan on using the service planning areas, given that there's roughly 10 million people in LA. Figured that it made more sense to have a little more geographic and population-based granularity as opposed to the two covered California rating regions. And so that's the rationale behind using the 8 regions for LA instead of the 2 service planning areas, or the 2 covered California regions. Last sort of bucket of decisions or categorizing and understanding spending measurement. I'll work on that one for next time. With regard to confidence intervals, I know that that's a topic that we've discussed here. We do plan to collect the standard deviations to enable the calculation of confidence intervals at the provider and payer entity. This also helps us assess variability in spending. Again, what we ultimately report on and how we use that is still, I think, future topic of discussion. As far as demographic risk adjustment, I know we've had a robust discussion about that already this morning. We do plan to collect age and sex data to enable the demographic adjustment when measuring year-over-year spending growth at the payer and provider levels. And then lastly, a topic that we've discussed was truncation, or the idea of recoding high-cost outliers downward. And our plan for the baseline is to not collect truncated spending. In large part, there's not a clear or consistent rationale for how the truncation points could be set or have been set. And then you, in some cases, could be recoding downward a very large proportion of the spend. And so we wanted to make sure that we were collecting the full amount of spend, especially in absence of a clear way for how we could set those truncation points. Before we stop there, so all of these decisions will need to be promulgated by way of regulations. We have a data submission guide that'll be enacted through regulation. And so just to share with you the timeline in terms of how we plan to come back to the board and to the public with those specific regulations, as well as the data submission guide that will firmly encapsulate these positions and decisions, because all these decisions, as was noted, are tentative still. So in October, we plan to publish the draft regulations. In mid-November, we'll have a public workshop. We'll come back 2 weeks later to have a discussion of what we heard through that public workshop and also the board's reaction to the draft regulations, share with you what we heard at the workshop also. And then in December, we will provide an update of any sort of what the current status is, if there were any changes or modifications based off of the public workshop and the discussion that we have in November. Ultimately, we plan to submit to the Office of Administrative Law the emergency regulations package in late January, early February, which would make the regulations effective in the spring of 2024, which will set us up for our initial data collection, which will happen in September of 2024. So with that, I'll turn it back to the board for any questions or comments about the current tentative decisions.
Senator Panther.
At the advisory committee yesterday, they did ask about ERISA plans. So maybe can you just speak to how we're capturing that data? We're capturing, because we are going to get data from these plans. I mean, I guess they're acting as carriers or so forth. Is that going to be reported? So if you can just clarify that the issue on the ERISA, or essentially self-funded plans.
Yeah, most states have been successful in getting the self-insured plan data as part of kind of aggregating both the fully insured and self-insured lives. So the goal is for us to get it as well. And we'll be working, with the payer community on the data submission requirements.
Dr. Carla.
And yes, I want to again say to the department that I think that these positions are probably, with regard to the data, the most conservative to take at this point, and I'm comforted by the thought of further refinement as we go forward. But I think it's good not to kind of truncate our methodology early on in the process, and I think this is the way to proceed. I did have one question. It's mostly my memory. I want you to refresh me about workers' compensation. I know it came up earlier. I just wanted to see where we were landing on that.
So with workers' compensation, it would involve working with an entirely different set of carriers that are not the health plans that we're used to working with. So that would be out of scope for the purposes of looking at health coverage that's paid for through health plans.
And I would just add that under the statute, we actually don't have authority. The definition of the payers in the statute, I don't believe, includes workers' compensation. So we did, look at that, and it may be that we can note in the baseline report any data about that spending. Because I think what Vishal said earlier about needing to set the context of what is included in THC and what we know isn't will be important.
Rick and then Ian.
Thank you, Ian. what would I do without Ian? I'd be lost. Um, to follow up on David's comment, I do think it would be useful in the baseline report. There are certainly estimates of how much is spent on workers' comp. And similarly, and Vishal mentioned this, I realize we're not ready, given staff constraints, to report comprehensively on public health spending. We've had many conversations in here. I would hope in the baseline report that at least be some rough estimate of total public health spending and some plan about how to move forward collecting that in the future. I would hope that that's consistent with the constraints under which you're functioning. On the self-insured, I did wonder about the data sources for the administrative costs on self-insured. I haven't looked at NAIC reports for many years, and maybe they've changed. You know, what my dim memory, I'm not sure that NAIC knows about the administrative costs for self-insured plans. They may, but it's at least a question. It seems like a potential hole that maybe you know more about. Maybe it's not a hole.
Yeah, I don't have too much information on that, but that's something that we could follow up on.
Michael May.
So in other states, Rick, the states request that amount of the carriers, because you're right, it's not on the NAIC.
Yeah, that seems like it would be needed here as well. And then penultimate comment is, yeah, given the October draft regs, I can see that this is too tight. I mean, there are, and it needs to be processed with stakeholders, there are existing methodologies for defining what is primary care and what is behavioral health. And I would caution, Vishal, you talked about behavioral health in the context of professional spending, but clearly there's behavioral health in both outpatient and inpatient spending as well. I can imagine you don't want to just take one of those existing methodologies without having had conversations with stakeholders.
Yeah, that's right. Yeah, it wouldn't just be professional; it would be the full continuum of care.
It does seem like a shame to have the first baseline report without numbers on these two really important areas that, you know, where many people are focused on. But
yeah, we struggled with that as well. It's just so I'll start with primary care. There has been a lot of great work being done on this by various groups that have looked at the various codes that should be included and settings and providers. So we do think we're hitting the ground running in that area. We just needed to do broader stakeholder engagement to make sure, you know, if we're going to expect entities to or payers to report on this data, that we get their input and recommendations. So that's why it won't be ready in time for the baseline report, just because of the timing of the cycles that we have. But for behavioral health, there's actually been less work done on that in terms of defining those buckets of spending. So,
and I think if it were not for the stakeholder issue, there are methods to be adopted. But I understand that.
Yeah, I think the problem is if we just kind of let the payers use some different methodology or we wanted to be able to trend it, so we didn't want to have a change in methodology midway.
One last comment, or actually one earlier comment, which is I echo David's applause and support for the decisions that you've made. In the last comment, relitigating, but risk adjustment was raised again in CJ's comments. On September 7th, I think, MedPAC spent an hour and a half discussing how best to measure coding intensity and have updated their estimates and are now estimating that Medicare Advantage plans have risk scores that are 14% higher than the risk scores would be for the same person if she were in fee-for-service. So quite a bit bigger than their prior estimates. And then MedPAC's previous work, thinking about the very strong equity arguments that Dr. Pan and Ms. Rocco raised, MedPAC's previous work shows that there's a tremendous amount of heterogeneity among Medicare Advantage contracts, and I and others have done similar work. And so not clear, actually, that clinical risk adjustment introduces more equity, given the tremendous differences across plans in how coding is done. Sorry for the relitigation on it. But
A time check. We're at 20 minutes on this topic.
Thank you. Ian?
This may sound like a relitigation. I don't intend it to be. Back on the slide, the levels of reporting slide, I wanted to say this does look right to me, but I wanted to focus in on the commercial carriers piece of it for a moment. I'm just wondering, especially with regard to the health plans, whether we have the ability and whether you've considered reporting on, some schema of actuarial value of those plans. Going back to the equity question and the anecdote or the example Director Landsberg gave us, if trend is lower for those plans with lower actuarial value, that may not be a good thing. It might be a sign of unmet need or off-books, out-of-pocket spending that we're not capturing because the data's imperfect. And I'm just wondering your thinking on that.
Yeah, we have been tracking that as an issue in terms of what could we report alongside THC data as part of consumer affordability measures. I think that the tricky part with this data submission is that it is so aggregated. It's it's going to be payer data for the entire book of business. So it could be done, but it's getting it would be a separate data submission process in terms of doing an average weighted average AV for the entire, because then you're pairing benefit design in addition to the spending for that member. So that's something we can consider in the future, but we're just kind of trying to weigh how much to put in for data collection requirements and.
Very quickly, a clarification and a comment. So the clarification is I had been assuming when we were reporting total spending that we would be aggregating the payer-made spending or the payer-provided spending and the out-of-pocket consumer spending, at least on covered services to the extent that you've collected it.
Yeah, that's right.
And so at least for covered benefits, you have the ability to just divide payer spending into the sum of payer plus consumer, and you'll have an AV. Now, that you'll have an actuarial value estimate. Payer spending is 80% of the total, 70% of the total. That doesn't control for differences across plans in what the covered benefits are, but it would be a really good start, I think.
We could definitely take that back. So you're saying an AV calculation could be derived just from those two measures?
AV is the percentage of total spending that is paid for by the plan.
Okay.
And you've got total spending and you know the percentage paid for by the plan. You don't know if there are benefits that weren't included at all. And so if the plan is not providing some important category of benefits, it's not a really great measure of AV. But I don't think that's a big problem for most of our plans.
I had thought what you meant, Ian, was were we going to measure gold, bronze, silver plans differently in terms of their spending target? Because Rick, are you talking about just each plans at the same time we're looking at their spending target or their rate of growth to also look at how their AV changes year to year? Huh. Okay. We'll take that back. But Ian, I don't know if there's any clarification you want to give.
No, that was I hadn't thought of that approach, and I wasn't wedded to the bronze, silver, gold spectrum, but more at getting to the the canary in the coal mine of people deterred from getting care because they're in a low AV plan, and there's enough. It's not perfect, but there's enough uniformity of benefits at points that there's probably not very major categories that are excluded.
Elizabeth, please.
I have a different question, and maybe this goes in the category of things we would like to do, but I didn't, the categories of data collection were around hospital, inpatient, outpatient, long-term care. Are we looking at home and community-based care? Some of the, I know at least for affordability, that's a key consideration. We're looking at caregiving, unpaid caregiving. That's a big focus at CMS right now. Are there other ways to get at some of this cost borne by consumers that might not be showing up in the hospital or facility data?
I think it's a great flag, and we would want to take that back. I mean, I think long-term, we would include home and community-based services that are covered by Medi-Cal and other plans under long-term care, but certainly hear your point, and it has been raised by the advisory committee that as they're out of pocket for behavioral health that we're not accounting for, they're certainly also out of pocket for home health aides and the like. So appreciate the point.
Any other comments from the board? If not, I think we want to take some public comment. Yeah.
All right, we're now open for public comment. For equitable access, we'll alternate between those in the room and those attending online, starting with an individual who has their hand raised online. Steve Shortell, you are unmuted. Please go ahead.
Steve, you there?
Steve, you're unmuted on our end. You might need to unmute on your end.
How's that? Is that good?
Yes, that's good.
Okay. So health policy, health services researcher at UC Berkeley. This is a great start, and just a reminder to underscore, I think, what everybody realizes, but in order to maximize the learning from these analyses, to the extent possible, even from the get-go, not just do them by the silos, the 6 shown there on slide 3, I guess, but the cross-analyses as well. So for example, how much variation is there across provider organizations within the same health plans, for example, or look at the health plan variation total spending by region within the different kinds of regions and so on. And I think that will really help from the get-go maximize some of the learning involved in terms of behaviors and the spending that's going on within the state in the different regions, and where some of the continuous improvement interventions might best be placed.
Thank you. Looking to the individual in the room at the podium, please go ahead.
Beth Capel, Health Access. First of all, to thank the staff for including reporting by geographic region. I think we now have geographic regions roughly comparable in size to Rhode Island or Oregon. So that seems appropriate to us. Did not seem appropriate to us to be reporting on 39 or 40 million people and thinking that was sufficiently disaggregated. We also very much appreciate the idea of disaggregating by HMO versus PPO. That's a constant of discussion in California, given how important both are. We also appreciate not truncating the outliers. We felt pretty strongly that that would deprive you of information that was useful and important. On the final discussion about AV and affordability, I would note your sister agency, the Department of Managed Healthcare, does a report on AV for individual small group, and Dr. Pan recalls from the legislation, individual small group and the state regulated part of large group. There are also other data sources on large group, and there are researchers working on this. Rick's idea of very simply just doing arithmetic is also pretty appealing as a way to start. I'm always in favor of, multiplication and division. But I would say you have some fairly rich data sources on AV that have been tracking for some years. Large group reporting has gone on almost a decade now. So we've got a fair amount of information at the state level that is not available in other states. And the CHCF employer survey also provides useful information in the area. So I think we've got a lot of resources to work from. Thank you.
Thank you. Looking back to individuals attending virtually, seeing a hand raised. Kristen, go ahead.
Hello, thank you, everybody. Thanks for hearing me. I'm here on behalf of small business owners in California and nationwide, and I was alerted of this opportunity by the Small Business Majority, a small business education and advocacy organization that represents over 85,000 small business owners nationwide. I'm really excited that this committee and its work exists, so thank you. My name is Kristen Horowitz. I'm of the Pad Climbing. It's a climbing gym that I run with my partner. We have 3 locations across 3 counties, and we're based in San Luis Obispo. Our mission is to promote well-being, equity, and inclusion through climbing, both for its members and employees. Our healthcare is one of the most biggest concerns for me as an employer and as a business owner. 89% of small business agree with me on this point, and 71% feel that it should be a policymaker top priority. So again, thank you for doing this. My assets are my healthy, happy people, but even when we are providing 100% of cost for a silver level PPO, our full-time employees are still not able to provide, we're still not able to provide a wage where we're meeting the deductible and copays, making an easy choice for people, not even for me. Due to the high cost of real estate among cost of living issues, providing a living wage despite having a popular business is extremely difficult. Many of my employees, whether they're entry or mid-level or beyond, are unable to have basic quality of life to be able to live alone with their families, pay for basic household necessities, and maintain regular health care. More specifically, my team is women-led, and the women on my team, including me, are especially affected by ongoing medical needs for both their children and themselves, and current insurance costs are such a huge obstacle for women and head of households. I feel also that there might be some ageism based on the fee scales, based completely on age. I mean, there's a chart when you're doing business healthcare where we literally are able to see how much it's going to cost to bring somebody on and how it will go on ongoing. That might be causing some workplace insecurity for employees as they enter more robust years. And I've heard this from a number of peers and friends. I'm also really just grateful again for this opportunity to share my story at the very first meeting. The affordability of healthcare is a challenge for so many people, but especially for small businesses where the Affordable Care Act has put the burden on them and their employees. This board has an opportunity to make healthcare affordable for tens of thousands of low to moderate income and entrepreneurs and small business owners by setting spending targets that are grounded in real consumer wages and not just the wealth. Thank you.
Thank you so much. Turn to the person in the room.
Members of the board, I'm Steve McDougall, coming to you once again in person this time. I am a high school history teacher by trade. I'm also a union activist as well. It's kind of a parallel career I've developed, and I am not a math teacher. You don't want me to be a math teacher. And if I was to hold class up here for the Industrial Revolution or the Vietnam War, or to organize educators around a contract negotiations campaign, class would be in session. And you would get schooled and you would learn some things. But when it comes to articulating the existential conversation of healthcare and what I've observed today, I'm concerned that the anomaly of Monterey County, although not completely buried in the data, that it will be somewhat insulated. Lopping it in together with Santa Cruz County and San Benito County, those 2 counties operate much like the rest of the state. Once you cross that county line into Monterey, it is a whole different kettle of fish. I can't emphasize that point more. I'm also concerned about looking at plans covering 40,000 lives or more. I believe that will also hide the anomaly of Monterey County. I get splitting up LA County into several groups. I think you really need to look at the data of Monterey County. It is the absolute cause celeb of what's wrong with healthcare in California and America. And if it can happen there, eventually it can happen in other places. Thank you for your time. Thank you for listening.
Thank you so much. Turning to a member of the public online, Mary Sue, we're going to invite you to unmute, please. Mary Sue, we've unmuted you on our end. Can you unmute yourself? Okay. All right, turning to a member of the room in the room here. Please go ahead.
I'm Katie Bassler. I too am from Monterey County. And the first time we came to speak to all of you, what we asked for was for consideration in your work to carve out Monterey County and look at its specifics. I echo what Steve McDougall has just expressed. I could teach math though. Um, and I appreciated the comments of just looking at math. The math that we do in Monterey County is frightening to me as a labor leader and as a member of that community. Santa Cruz County is where I ask new parents to go deliver their babies because it's affordable, or San Benito County, but it is a further drive. Monterey County, we ask that you really look at it and not put it in together. Covered California plans are different in Monterey County as compared to San Benito and Santa Cruz County. Thank you so much for all the work that has been done. It's impressive. Thank you.
Thank you. Looking online, I don't see any other hands. Looking here in the room, no one else coming to the podium. Yep. So we have virtually Mila. Ludmila, we invite you to unmute.
Hello,
Okay,
can you hear me?
Yes, we can. Please go ahead.
Oh, well, nice to meet dear members of the board. I'm Ludmila Parada, and I'm the president of Nelly's Childcare and Preschool, which is a 100% female-owned, minority-led company located in Campbell, California. Since we started, it was important for us to prioritize a comprehensive benefit package for all our employees, including covering 100% of insurance premiums for our full-time team members. This has been always seen as a vital investment in our workforce, but it's very expensive. After wages and rent, healthcare insurance premiums are our third largest expenditure, and these costs continue to rise year after year with lowering coverage and no end in sight. As a small business, we face daunting challenges in providing healthcare benefits. Covered California offers a meager selection of insurance options, and the initial subsidies that once aid small businesses have vanished. Private insurers offers no respite either. Last year, I shelled out nearly $60,000 in premiums to HealthNet to insure only 7 employees. Shockingly, during this period, none of them could access a primary care physician because none of the physicians listed by their system as accepting new patients were in fact available. Complaints to their customer service fell on deaf ears, leaving us a small business with minimal bargaining power. We can only hope that our new insurer can offer some semblance of care. The presence of an aging workforce has significantly driven up our insurance expenses. We are typically quoted based on the age distribution of our staff, which has severely limited our ability to increase salaries or extend coverage to their spouses and dependents. For an employee in their mid-50s, the cost of a health insurance is equivalent to approximately $5.50 an hour, a sum that could make a substantial difference for the average childcare worker in the California Bay Area who earns an average of $22 per hour. Thank you.
Thank you so much. I don't see anyone else coming to the podium here in the room, online. I see no hands.
Great.
And that completes public comment and back to the chair, perhaps for a break.
We're going to take a break. Vishal's got a couple more things he wants to do, and then we'll take a short break. Vishal.
We've discussed the spending target generally. Now we'd like to dig deeper on the methodology for setting a target. CJ Howard, Assistant Deputy Director, will be covering the statutory requirements for the spending target.
Back again. I think I'll be even more brief than I was the first time, and then we can get to a short break. So I'm just going to tee up a little bit about the spending target, actually setting one. I feel like this is the moment that we've all been waiting for, or at least I have. We've been talking a lot about how we're going to measure performance against the target, what data are we going to collect, who will that data be collected for, and how are we going to aggregate it and split it and dissect it and analyze it. But now we get to actually talk about the target setting methodology. So I'll do a quick overview on what a target is, a brief timeline about the implementation of the targets and how they phase in the coming years, a little bit about the statutory charge, before I'll hand it off to Michael Bailett to talk about other states' experiences and some of the factors that we may want to consider, and they're certainly just food for thought and a starting place for, I think, broader conversations. So healthcare spending target is an annual rate of growth expressed as a percent change from one year to the next. Generally, when we look at other states, they're set somewhere in the 3 to 6% growth rate. It's thought of as the upward bound on healthcare spending growth. States adopt these targets in an effort to slow growth in healthcare spending. Healthcare spending, as we know, has long exceeded economic growth, and per capita spending on healthcare has grown faster than inflation, wages, and other consumer measures, making healthcare increasingly inaccessible or unaffordable for many. So today's goals, first we're going to review the statutory requirements and considerations, including the board and OCA responsibilities. Statute splits those out separately, and a timeline for how the targets get phased in over time. We'll review other states' methodologies. We'll introduce some of the economic and population indicators and consider tying target value to one or more of them. Again, this is just a starting place for further conversation and exploration. And then we'll review factors identified in statute for possible spending target adjustment. So I hope that this helps kind of contextualize the next many years worth of work and thereafter. At the top, we can see that in 2024, we're starting today the discussions around setting the spending target. But by 2024, we need to set the first target for calendar year 2025. Just to kind of show how this all phases in, the 2025 target that we set, we won't actually report on that until a report that OCA will issue in 2027. That'll be our first statutorily mandated annual report, the data for which we'll collect in 2025, and we'll be comparing the growth in spending that occurred between calendar year 2024 and calendar year 2025. That first annual report is not subject to enforcement mechanisms. The first annual report that would have enforcement mechanisms attached to it will be based off of the 2026 target, and that would be the difference in spend between 2025 and 2026. And then we would continue sort of in this fashion for the years to come. Backing up then, so just so we're all clear, a lot of what we discussed today was about the baseline report, which is mandated in statute. We'll be collecting those data in 2024 and then reporting on that in 2025, and we'll be comparing the growth in spend that occurred between calendar year 2022 and 2023, but there's not a target that's set. We won't be reporting against a target. Also, so that we can continue to perfect and refine our data collection and our data reporting and our analysis tools, we will also be doing a 2023-2024 report that would come out in 2026. I also, just a note, and we'll talk about this, when the board sets targets, it has the authority to set it for 1 or more years into the future. I think Michael Bailey will talk more about this. I think most states have opted to set them 5 years at a time. So, but I think per statute, the requirement is that in 2024, we set the 2025 target. Okay, so the statutory requirements for setting the target. So the board shall establish a statewide healthcare spending target for the 2025 calendar year and for each calendar year thereafter. The statewide target must meet the following criteria. And so what I'm going to talk about is the board requirements for actually setting the target. And then also there's a couple slides about what OCA's responsibilities are, where we develop the methodology in coordination with you for the board's approval. But in the actual setting of the target needs to promote a predictable and sustainable rate of change in per capita total healthcare expenditures, be based on a target percentage with consideration of economic indicators and or population-based measures, be developed with a methodology that is transparent and available to the public, and be set for each calendar year with consideration for multi-year targets. And if that wasn't an easy enough task, there's still a few more requirements. It must be developed and applied and enforced. It needs to be updated periodically and consider relevant adjustment factors. It needs to promote improved affordability while maintaining quality and equitable care. including consideration of persons with disabilities and chronic illness, needs to promote the stability of the healthcare workforce and be adjusted for provider entities to account for growth in organized labor costs. Additionally, the board shall establish specific targets by healthcare sector, including fully integrated delivery systems, geographic regions, and individual healthcare entities as appropriate, except for that's inclusive of fully integrated delivery systems. Sector targets must be established on or before June 1, 2028. Therefore, the board will focus on the statewide target. So I think for today, we're going to try to focus first on the statewide target, also teeing up some of the future work around the sector-specific targets and other adjustments to come. And again, the deadline would be it's established by 2028. So how do we go about setting the target? OCA is responsible for developing a methodology that's to be approved by the board. The methodology needs to meet the following criteria: be available and transparent to the public based on a review of historical trends and projections of economic and population-based measures, based on a review of historical cost trends with differential treatment for COVID-19 years, consider potential factors to adjust future cost targets, including but not limited to healthcare employment cost index, labor costs, CPIU, and other factors. Consider several criteria related to Medi-Cal, including but not limited to the non-federal share of spending, maintaining federal requirements to ensure all federal financial participation in healthcare-related taxes or fees provide the non-federal share. It also needs to allow the board to adjust cost targets downward when warranted for healthcare entities that deliver high-cost care that is not commensurate with improvements in quality. It also needs to allow the board to adjust cost targets upward when warranted for healthcare entities that deliver low-cost, high-quality care. And it needs to requires the board to adjust cost targets as appropriate for a provider or fully integrated delivery system to account for actual or projected non-supervisory employee organized labor costs. Additional criteria apply when setting sector-specific targets. Potential factors to adjust future targets. So this is all just for the gestalt of our thinking and as we're setting these targets. The statute requires the methodology to consider possible adjustments for at least these potential factors: the healthcare employment cost index, labor costs, consumer price index, impacts due to known emerging diseases, trends in the price of healthcare technologies, provider payer mix, state or local mandates such as required capital improvement projects, relevant state and federal policy changes impacting covered benefits, provider reimbursement, and costs. I hope that that's all clear as crystal as we go forth in this endeavor.
Dr. Pan?
Thank you. I would make note that in the statute, these are shall. So it's not as quite as optional as it seems to be phrased there, but we need to take account of those things. Thank you.
Any other questions or comments from the board? Richard?
One question, which I think I asked at the first or second meeting, is around timing, with particularly some of the authors of the statute in the room. CJ, you noted that the requirement is to set sector-specific targets by 2028, but enforcement starts in 2027, which implies at least that the entities that for against which the targets will be, or for whom the targets will be enforced, need to be decided on well before 2028. Do I understand that correctly, or am I missing something about the 2028 date?
So the enforcement that would start in 2027 or 2028 would be this as to the statewide targets. So 2025, we have a statewide target that's not enforceable. The first enforceable year is 2026. The sector targets in 2028, that enforcement wouldn't be until 2030.
Maybe my confusion is about what sector means, because
it can either mean geographic sectors or sectors of the industry.
Right. And so how would the statewide target possibly be enforced without having to find some smaller level thing?
So I'm Health Plan A.
Right.
And we're measuring my spending from 2026 to 2020, from 2025 to 2026. And as to, so the statewide target is whatever amount, and we're measuring to see whether we complied with that.
So that implies that we've decided that the health plan is an entity for which the target would be enforced.
Yeah, the statute goes through which entities are subject to the cost target, health plans, and then a group of 7 different types of providers, and then the fully integrated delivery systems, which is Kaiser. We haven't satisfied you, Rick.
I'll be quiet
Come
for
back.
now. Thank you.
Dr. Pan.
So just to clarify, based on what you've said, and is that the statewide costs? So we're eventually going to get to sectors, but what we're going to do is we're going to actually apply the statewide to every single sector or every single entity equally before then. So I think that raises, yeah, I think that's what, so it's interesting because we were going to first set one number that apply to everybody, and then we're going to recognize that actually people may be a little different, and that's why we're going to do sectors and geographies and so forth. But we're going to first hit everyone with the same number. I think that's there's a little bit of a cognitive dissonance there, you know, that it would be in that approach.
Elizabeth?
My question might be related. So is there an option here where you could have a spending growth target of, say, 0 for commercial and allow growth in Medicaid, just still get the same average? Or regionally, could you say maybe a 0 or negative target for Monterey and increase in other underserved regions? Would that work here?
At the point in time when there are sector targets, yes, you could have a different target for Medi-Cal versus commercial coverage, or different regionally.
And that would be in 2028. Is that correct?
It could be on or before. There is discretion for the board to set the sector targets sooner. But the targets cannot be negative targets. They do have to be targets on growth. Yeah.
But flat counts, correct?
It could, as long as they're above 0.
So could you just explain that to me? Because again, I defer to the math teachers in the room, but negative growth is a thing.
It's an earlier version of the language for OCA did propose, you know, the targets could go in a negative or positive direction, but what was ultimately landed on was that the targets are about growth. So growth would be anything above 0.
Did that answer your question, Ian?
And you know, through this process, there would. Yeah.
And I do just want to clarify that the statute says not later than June 2028, the board shall establish sector targets. So the board could choose to establish sector targets at the outset, correct?
Yes.
Super helpful. Any other questions from the board? Okay. If not, let me suggest that we take a break.
Yes.
It's 2:40. We went to 15 minutes. Okay, so we'll see everybody at 5 minutes till 3. Thank you. let's, where's your boss? If I could get everybody to take their seats, we'll reconvene from our break. I want to thank everybody who's attending virtually. Appreciate you accommodating us while we took a little break. Vishal, I think you're going to want to continue this with Michael.
Yes.
Good afternoon, everyone. I want to start by acknowledging the public commenters a little while ago who reminded us, I think, why we're here and the pressing nature of the problem. I also want to acknowledge Steve Shortell, who was the first commenter, who was my academic advisor in graduate school, and without whom I would not be standing here before you today. So thank you, Steve. All right, so I'm going to spend a little time reviewing with you how other states have set their spending targets. That doesn't mean that you need to do the same, but I think it's helpful context. And then I'm going to share with you some potential options to consider for indicators that could inform setting the value. This is going to be the first of a few conversations we're going to have on this topic, so consider this to be introductory. So as the slide says, to date, there have been 8 states that have set healthcare spending targets. You see them listed here. They all, in some manner, tied their targets to a measure of economic growth, either the state's economy or some indicator of the economic well-being of the residents of the state. Point there. Okay. Okay, so they all had some type of a governing body. Sometimes they had a couple of them, as we have here in California. And they all asked the question for each indicator, is this relevant to what we're trying to do, meaning our purpose, our mission? And what would be the message if we adopted one or more indicators as the basis for setting our value? All right, I'm going to ask you guys to advance the slides, if you don't mind. Okay, so when doing this, they all looked at historical spending in their state across 3 different markets, the trend rates for commercial Medicaid and Medicare. Thank you, CJ. Historically are quite different. I'm sure we'll find the same for California. As CJ indicated, they have all set multi-year targets. You have an option to set 1 year or multi-years. They're as short as 4, as long as 10, most, as CJ said, 5 years in duration. I want to note that there's a rationale for setting targets for more than 1 year, and that is, as CJ explained, it takes 2 years to gather and report on information. So you can't assess the impact of the spending target until 2 years later. So if you set a target for only 1 year, you would be setting the next target before you know what performance was for the first year's target. So that's a rationale for having multi-year targets, so that experience can inform setting of the next round of targets. So the targets that have been set or were set between 2018 and 2022 in the other states ranged between, actually 2.9% is a little high. In Nevada, they went lower to about 2.4. So 2.4 to 3.8. Generally, when they set their targets, they were setting targets that were a couple of percentage points below the historical spending growth in the state. I say in the state. That's not true for each market, because generally spending growth in the commercial market has been much higher than it has been in the other 2 markets. But overall, the targets were a little bit below. That was not planned. That's just incidental in terms of the experience that they had. So I'm going to share with you, but not discuss in great detail, the target methodologies and the targets for 8 states. So they're listed here alphabetically, the first 4. There are a few things I want to call out. One is you will see for all of these states that actually for all except for Delaware. No, actually Delaware and Massachusetts. So Delaware and Massachusetts and Rhode Island were the first 3 states. Delaware and Rhode Island copied Massachusetts, and Massachusetts used one indicator, PGSP, a forecasted growth of state economic growth, which I'll explain. But after those 3 states, the other states began considering use of multiple indicators. And so they use and are using some form of a blend of more than one indicator. So that's observation number 1, the trend after the first 3 states to use a combination of multiple indicators. 2, they not only set multi-year targets, but the multi-year targets varied by year. They tended to select a value and then to start a little above that value and pursue a stepped approach to get to their desired value. Okay, that was considered to be sort of a transitional strategy. Elizabeth?
Sure. So is it fair to say that if providers or whoever knew that these targets were coming, that increasing their rates now would give them a, more room in the future?
Certainly there is an incentive to grow your prices and your costs as much as you can before the target becomes effective.
And did you see that in other states?
No. And I would say principally because most contracts are multi-year contracts. And so unless you were lucky enough to be negotiating your contract before it went into the target went into place, you didn't have the flexibility to do that.
So I guess my question for the staff is, since we're seeing 20+% increases right now, is there a way to calculate that into, the pre-target spend and maybe deduct it from the average?
Yeah, that's a challenging question. And I think that's something we're going to be definitely monitoring with all the rate increases that we're seeing. I think there's an opportunity with sector targets. I do want to remind everyone that 2020, it does say honor before 2028. So if the statewide approach or the statewide target is that's more of a one size fits all, kind of one number for everyone. But if there is a segment of the industry where costs are problematic, then sector targets could be an approach to really target that sector, because the sector target's pretty broad in terms of who they could apply to. It even says individual healthcare entity, so it does allow for a more tailored approach, so we could have a more aggressive target for a particular entity.
Do you consider maybe starting after, like saying we're only counting before 2022 for the baseline?
For the first target is for the 2025 year. So, your question is, if there are increases from 2023 to 2024 that are 20%, is there a way with a 2025 target to directly address that? And the limitation of the statute, as we talked about earlier, is we cannot require a decrease in spending. The most we could do is a 0 or 0.1% spending growth target. So I think we'll definitely want to look at that data over time, and I think it's an important point for us to be watching what's happening this year and next year.
Dr. Carlo? Yes, and thank you, Michael. Question, I think we may be getting into this later, but you mentioned the appearance of incorporating blended methodologies across the different states. Maybe the states that jumped on spending targets earlier use the economic growth target primarily. I don't know if that's an overstatement, but what is some of the rationale for the blending of the different methodologies?
So I'd say the states that blended and there are a couple of them here, Connecticut and Nevada. They did so because they felt that linking healthcare spending growth to state economic growth was insufficient because it didn't connect sufficiently to patient or consumer experience. And so they introduced some consumer-oriented economic indicator. So they didn't completely drop state economic growth, but they thought that they needed to have a balance of the two. And that's what you see here with Connecticut and Nevada, and you'll see it on some of the other states in the next slide. The last thing I want to note here is that there are what are described as add-on factors. So these are the values that are added on top of what they identified as a long-term target. So for example, the top Connecticut, 2.9% was the result of their 80-20 blended calculation, but they decided we're going to add 0.5 percentage point for the first year and 0.3% for the second year. There's no science to that. They just decided that they wanted to create a transitional path, but there's not an empirical formula that got them to those add-on values.
Yeah, if I could just pick up on Elizabeth's point. In this state health plan, at least large group contracts are typically 1-year period, which I realize might be different from more self-insured markets where provider contracts run 3 years or what have you. But you know, I'd ask staff to look at the question if what is happening right now, and it certainly seems to be that health plans are reacting to this body and this law preemptively and driving up prices, that to me speaks to that is a market failure. That is a failure of the market to provide adequate competition and keep reasonable rates. I know DMHC has some ability to look at reasonableness, but I wonder in the context of market failure analysis, we shouldn't be looking at that.
So here are 4 additional states. There are 3 points I want to pull out here. One is all of the states that are using more than one indicator, with the exception of Oregon, have taken a formulaic approach. So you can see 80-20 blend, 75-25 blend. So it's a arithmetic calculation. Only Oregon took a non-formulaic approach where they looked at economic growth, median wage, and then they already had a Medicaid waiver that had a growth cap built into it. And they had passed legislation that capped growth of their public employee programs. And so they used all of those to arrive at 2 different rates, one for the first 5 years and a lower one for the second 5 years. So that's a point I want to call out. I want to note the exception of Rhode Island. So Rhode Island's initial cost growth target period ended in 2022. So they had to set new targets for 2023. Rhode Island does not have a protected body, which is how I would describe this body, that sets the values. Instead, they are operating under a multi-stakeholder compact. And so the way that they arrive at their values is through group negotiation, facilitated by the state. And there was a strong argument being made by the provider sector that inflation and labor costs had spiked for them and that they needed to have a higher target. The result, and I'm whittling down multiple months of negotiation, but the result was to lift up their target to elevated levels for 2023 and 2024 with a slight add-on for 2025, and then going back to the long-term target thereafter. Okay, so that's the only state that for which the targets were significantly modified or modified at all for recent economic activity. Richard?
So you explained the rationale for multi-year target in the beginning, right? Because of, it takes a couple of years lag to get the data and so forth. so I guess the question is for these states. I mean, suppose they do 5 years or 10 years or whatever. When do they go back? So I guess now that you got ahead of it, should are states like doing it year after, adding a year, or they're doing like another 5 years, and when do they start the next 5 years? So yes, I get the beginning. You start off with a multi-year, but what are they doing subsequent to that? Are they still doing multi-year and then wait till the end of that, close to the end of that year, or instead of like an ongoing rolling thing once you got ahead of it?
Yeah, so I have a couple of answers to that question. Generally speaking, they stick with the multi-year, and in the year before the last year ends, they talk about the next 4 or 5, however many years. The exception is Delaware, which has a finance committee advisory body that does an annual review to affirm maintaining their target. Finally, so it's a 3-part answer. Finally, I think all of the states have some provision that allows for reconsideration of their targets under special circumstances. How they define the special circumstances varies, but there's essentially a trapdoor that allows them to reconsider. And in fact, the last couple of years of economic disruption caused a number of these bodies to say, okay, should we change our targets or not? They all decided not to do so. And the rationale, I would say uniformly, was that spiking inflation was putting only greater economic pressure on consumers. And so they felt that from a consumer protection perspective, it was not the right thing to adjust up their targets. And so they didn't do so. But they all had provisions that allowed them to step back and say, okay, the special conditions trigger has been tripped, and so we need to talk about this.
But none of them changed their rates because of that special trigger.
Right. None of them chose to, but they had a trigger that led them to have the conversation.
Richard.
Michael, I remember you telling us that in Massachusetts, if entities exceed the target, they go through naming and shaming and then potentially a performance improvement plan. I don't remember what you told us about enforcement in other states, and I guess in particular, are there any other states that have the sort of pay back every extra dollar provision that California does? So
the only other state that is similar to California is Oregon. So Oregon has a provision that starts with a performance improvement plan that's similar to Massachusetts. And then for repeatedly exceeding their spending target, there is a financial penalty. The statutory language, I believe, is pretty generally stated in terms of the amount and how it's calculated. But that's the only state that has a financial penalty for exceeding. As of now, I will say that the states that do not have provisions or that have soft provisions like Massachusetts are now actively having conversations as they see their targets being exceeded about whether they need to have additional authority. Okay, I think that covers everything I want to touch upon on this slide. So our statute that we are working with says that the statute shall consider economic indicators and population-based measures. Population-based measures is not something that other states have considered, so this is going to be uniquely Californian, at least so far, uniquely. So we will review with you possible economic indicators and population-based measures. In identifying measures to share with you, we considered measures for which data are publicly available today, both retrospectively, so historical data, and where there are also available forecasts. So that's a limiting condition. That doesn't mean that it might not be possible to find forecasts where there are not right now. And maybe you won't care about forecasts because maybe you're going to say, we don't care about forecasts, we just care about historical data. But but leaving open the possibility of using both, we focused on indicators where data would be available to you.
Go ahead, Richard.
And just to clarify, I mean, this is to establish the initial target because we have those other adjustments that were presented earlier for as we roll out subsequent years.
Yep. This is just for the initial target. Yeah, go ahead.
So I understand that all these other states have just looked at historical trends. So
no, I'm sorry. They've looked at historical trends and they've looked at forecasts.
Okay. But have they just looked at the cost of providing care like Medicare does? So Medicare rates by law reflect the cost of services. And the research all shows that hospitals should be able to provide equivalent care for a max of 160% of Medicare. And have they ever considered any of that in their target setting?
No, because their focus has really been on slowing healthcare spending so that it's affordable to consumers. So their lens has been what's a reasonable rate of growth, not what are provider costs. Okay?
Right.
Right or wrong?
Presupposition was that that would be lower than what is currently being charged. 160% of Medicare.
Yeah, but I'm just, that's not been their lens.
Okay.
So the statute says with regard to economic indicators, measure the broad economy, labor markets, consumer cost trends. It's general language. So I'm going to share with you an initial sample of potential indicators that you could utilize. It's a first list. If there are other indicators that you think are compelling, we can introduce those for a discussion at the next meeting. Yesterday, during the meeting of the advisory committee, we made the same comment, and if members of the public want to suggest indicators, they can. So this is just a first discussion list. I'm going to present them one at a time and tell you what is the indicator and what might be the received message if you adopted it to inform the value of the spending target. So these are the 6. The first 2 are focused on the state economy. The next 3 are what I would describe as consumer experience-centric measures. And the last one is a population-based measure. So I'm going to start with the economic measures. And please interrupt me with questions or reflections as we're going through this. I mean, you've been doing that already, but I just want to affirm you are invited to do so. Okay, so today I'm just sharing what's the indicator measure and what's the message. The actual rate of change historically and what the projection is, we're going to share at the October meeting. So today we're just talking about the merits of the measure concepts, and we'd like to get your feedback on what resonates for you and what does not. But we will introduce data points to you at the next meeting. I've referenced historical and forecasted data. I just want to mention that both are data that you can use to inform the target. The historical data is usually easily available. It's characterized by a lot of volatility. And that volatility reflects the fact that our economy tends to be volatile. And that's going to be reflected both in measures of the overall economy, but also in the personal finance experience of residents of the state. And so when we measure historical experience, the duration of the look-back period is going to significantly influence the results. The longer we look back, the more we account for cycles of upward growth and of slowdowns. It is fairly easy to calculate historical rates of growth, and it is possible to adjust for extreme events by smoothing or expanding the time period. Forecasted data provide much smoother figures because the future always looks smoother than the past was, especially if we're looking at longer term periods. For example, if we're forecasting 5 years out, it's a constant value. The forecasts are, of course, informed by past experience, so you're not going to see wildly different figures for forecasts than you see in historical experience. The forecasts are generally developed by the federal government, by state agencies, the Department of Finance in California, and by private forecasting firms like Moody's Analytics, and there are others. The methods of forecasting are variable, and so you will see different forecasts depending upon the source of the forecast.
And Michael, the forward-looking forecasts are usually for what period of time?
It depends who does them. The Department of Finance's forecasts are relatively short. They're only a few years out. Some of the private forecasting firms, they'll give you a 10-year forecast.
Well, in the government, we have both finance, we have LAO. So I think usually when we do our state budget, they kind of run it out about 5 years. Obviously, we budget year by year, but so I believe finance does sort of provide at least some form of projection out to about 5 years.
Okay, that's good to know.
And same with LAO.
Okay. Thanks. Okay, so I'm going to go through the indicators one at a time and then ask you to reflect on which ones resonate for you and if there are any others that you think should be considered. So gross state product is the state version of the federal GDP, and it looks at the value of goods and services produced within the state on an annual level basis and how much they're growing. It's calculated pretty similarly to GDP, but not exactly the same. And so this tells us how's our economy doing. And if you were to tie the benchmark to GSP, you would be saying healthcare should not be growing any faster than the rest of the economy. Healthcare, of course, is a portion of the economy and not an insignificant portion, but we'd be saying shouldn't be growing any faster. Potential gross state product I'm listing because this is the measure that the first 3 states, Massachusetts, Delaware, and Rhode Island, adopted. This, and it's a measure that a number of the other states are using now in blended calculations. So this is a calculation of long-term expected rate of growth in the state economy. It differs significantly from GSP. It is not a forecast of GSP. And on the next slide, I'll show you why. But this measure, like GSP, is a measure of state economic growth. And here again, if you were to adopt it, you would be saying, we believe that healthcare spending should not grow faster than economic growth is forecasted to grow. This next slide shows you the differences in how the two are calculated. You can see they are wildly different. Gross domestic product at the state level is income and business taxes, whereas PGSP looks at labor force, growth, productivity, inflation, and subtracts out state population growth. All right, so now 3 measures that have to do with the economic experience of Californians. So the first one is median family income. We pick median here because we know that that income has a long right tail, and that the experience of those with high income has been that it has been growing faster than the rest of the population, and so we adjust for that by picking the median value. And we're measuring family income, which is all related members of a household. That's how this measure is calculated, and reflects the fact that oftentimes members of a household pool their resources. So this measure assesses essentially, if you were to utilize it, would say healthcare spending should not grow faster than the income of California families. Okay, very different than state economic growth. Richard?
So what's the source of determining this data? So is it tax information, or I mean, I guess because people have to define their household, right? And then of course, obviously report their income for income tax. Are we going to be missing people who don't pay the sources income tax revenue, who don't pay income tax, or who don't file because their income's too low? So just wondering as to how robust this is and where the data is coming from.
Yeah, so let me report back to you after the meeting the technical details of this measure.
Rick?
You can help?
I think it's the case, but you should confirm or not, that states that use this take the data from the current population survey, which is a household survey conducted by the federal government every month. There's a March supplement that gathers data on information from the prior year. So it's not from state franchise tax board. And the census, which conducts the CPS, has a well-worn and time-tested method of defining households.
Yeah, but I'll note also that the data source will vary based on whether you want to use historical data, which is what Rick just described, or use a forecast. And we will talk at the next meeting about the pros and cons of using historical data and forecasts, and we will share with you historical data and forecasts so you can see how they compare. Okay, the next measure is average wage to Californians. You will ask why average wage, not median wage, and that's because the Department of Finance forecasts average wage. They don't forecast median wage. Wage is a narrower construction than household income because wage does not include other forms of income that households might have, other forms of income that are going to be more common with higher income households. And so if we were to choose average wage to inform the target value, we would be looking at essentially take-home pay and say healthcare spending shouldn't grow any faster than the wages of Californians are growing.
I hear the concern that Department of Finance doesn't forecast median wage, but median wage does seem like a much more conceptually appropriate measure. I mean, average wage is heavily influenced by the wages of people making $1 million or $2 million. Right. And certainly there's historical data on the relationship between average wage and median wage, which has been diverging, average wage going up, I think, more quickly than median wage. But it seems like that historical relationship could be used along with the DOF forecasts of average wage to construct a reasonably good estimate of median wage, which would seem more appropriate to than average.
Yeah, I will also say, Rick, we have not asked the Department of Finance that if we offer them a Reese's peanut butter cup, would they be willing to give us a forecast of median? That might be another possibility.
And I guess a similar question in terms of, again, data source, but also there's a difference between wage and income. So, right, so in terms of what gets counted, right? So, I think Steve Jobs made a wage of $1 a year, but he got lots of stock options. But you also have other people who maybe, if they're working off the books or so forth, wouldn't be reflected in a payroll, right? So on the low income side.
Our third consumer focus indicator is inflation, or CPI. So you're probably all familiar with CPI. It measures consumer experience with a collection of retail goods. The CPI All Urban, or CPI-U, captures the experience of almost all Americans. It's possible to measure this as core CPI, which excludes food and energy, and which is somewhat volatile, or to include food and energy. Either way, this is a measure of how much household expenses are growing, and so we could say and household prices for consumer expenses are growing, and so we could say healthcare spending should not grow faster than the rise in consumer prices. Now, in some states where they've talked about this indicator, there's been a debate about, is healthcare a price? And technically, healthcare spending is a combination of utilization and the prices of the services. But from a consumer perspective, a premium is a price, and a healthcare service that you pay for out of pocket is a price. So you could make an argument, I think, that from a consumer perspective, healthcare is in fact experienced as prices. Elizabeth?
Why is it relevant what inflation is? How does, I don't understand why we should consider that for hospital or healthcare prices, because it really isn't tied to affordability.
Mm-hmm. So that where I'm giving you a menu of options, and I'm not really at this point speaking for or against any of them. Just sharing it with you.
Fair.
Yeah.
Have you ever looked at how much healthcare drives inflation across sectors? Because that's also interesting.
So healthcare spending and inflation have an interactive relationship. Yeah, there's not unidirectional causation. Okay, and last, our population measure, median age. There might be other population measures that you would like to consider, but certainly there's a relationship between the age of the population and healthcare spending, as we talked about earlier and in other meetings when we've talked about age-sex adjustment of spending growth. And so it would be possible to incorporate the aging of the population into the spending target, probably not having age be the sole informer of the target, but perhaps in conjunction with one or more other indicators.
So when we talk about age, because you say median, but we know that spend related to age is not essentially a linear, right? So when you're really young, although less frequent, can get very expensive, it drops, right? And then it goes up, and then depending on how old you get. So it's not a linear. So I think that using median age is the assumption therefore is linear. So therefore the median age moves up, et cetera. But I think what we need to better reflect is the actual curve in relation in terms of because acceleration in spending or utilization, if you want to call it, because we want to try to actually talk about actual need, not just how much we spend. The need for healthcare services, I don't think just goes up linearly as you get older. It's kind of flat for a while, and then it really starts. And then when it's a great point. So whatever measure we use for age should perhaps actually reflect that, and not a median or a linear. I'm trying to think what sort of mathematical, statistical thing we'd use to reflect that.
To follow up on that, I mean, it seems like it'd be pretty straightforward to take information on spending by age group, 5-year age buckets or maybe 5-year age and gender buckets available from MEPS, not perfect, but, not terrible, along with information on historical and projected numbers of people in California in each of these age buckets, and calculate the effect of changing age distributions on expected spending,
right?
And perhaps have that as an add-on to whatever indicator. We haven't talked about add-ons, which I'll come back to. But
Yep. I agree. Any other questions or comments?
And maybe because I got a chance to hear this presentation before, but
it's sinking in.
But because I know, because you talked about this is the one population measure. So the question is, are the population measures? Maybe you're about to get to that, and I just jumped the gun here. But we did talk about age, sex. Now I don't think, hopefully, we won't have a dramatic change in this distribution by sex, from year to year, but that there is there. And then I guess the question is that recognizing the challenges of structural racism and so forth, and there has been a changing demographic in terms of racial ethnic distribution in the state, and whether, again, maybe the magnitude isn't large enough that it would affect a statewide target or a geographic target, but I think something we just need to at least look at and acknowledge. And then also from a demographic standpoint, there might be some measures about, percentage of people who have significant disabilities that we might be able to collect from other government databases, that if that is rising as a percentage of the population, that's separate from age. I mean, some that may be related to an aging population, but I mean, there's other events going on that would, and generally they would have higher healthcare needs. So again, that needs, not spending. So but that we want to have a target that allows people to meet the needs that people have, right, and deliver the services they need. So I think those are some other potential population things to think about.
I'm curious, other states didn't use any population measures. Did any of them consider it? And if not, why not?
In my experience, it was never raised.
Yeah.
Yeah, I want to acknowledge and appreciate your recognition on the question of income inequality. Just to tease that out a little bit more, because I think it's important here. California has among the very highest income inequality factors in the country. And to me, just as we're thinking about this from first principles, our charge is affordability. If my income is going up, I can afford more. If it's not, I can't. So, my starting point is income, maybe wage, but income-based measures. I think that income inequality and how it's tracked over time, I think it is getting worse over time, is to me an absolutely essential factor that we all need to be thinking about here, because gross state product doesn't account for that. It can go off the charts, as it has done, and leave huge numbers of people behind. Likewise with inflation. And I just say my intuition, as you mentioned, the inflation question is circular, right? That healthcare costs can drive inflation, can drive healthcare costs. That seems to be true of gross state product as well, that there's some circularity there.
Could I just,
and then David?
I want to fully agree with that. And, we keep hearing from folks who are trying to afford care and businesses that are trying to afford care. And if we're not really focused on income and ability to pay, we're just not going to hit that mark.
Yeah. David?
And mine's a follow-up question or statement as well. In my sense, California is a very high economic performance indicator state. Our per capita state economic product is maybe at the top end of the United States. I'm not really sure about that, but to that degree, or to that point, that does exacerbate the difference between income measures and economic performance measures in the state of California. So I definitely feel pretty good about using blended approaches that incorporated both, but weight tended more on the income measures, which I think has been the historic trend across the country so far.
Okay, so you're sort of leading into the next slide.
I thought it was, yes.
But that's okay. So you've asked a number of questions. So now I think Vishal is going to ask you for suggestions.
Does the board have questions or suggestions regarding the use of one or more of the economic indicators or additional population-based indicators?
I mean, to add on to the consensus started by Ian and Elizabeth and David, I also think it makes sense to look at. I'm not sure actually between the wage and household income. I think I would lean more towards wage, but I'm not sure that I understand the issues or have a very strong preference. Very strong thought that median wage makes more sense than average wage, which is just skewed by the high end. My one request or thought would be at the next meeting, and this may be your plan in any case, some consideration of the add-on factors that, various states have used. We, or at least I, have talked today about potentially an add-on factor for aging of the population. You had mentioned in one of the slides, technology change. I mean, I am struck that in most of Western Europe, where healthcare spending is, much more under control of the government, mostly governments have chosen to increase health spending as a share of the economy, which is what gets reported, but I'm pretty sure as a share of median wage as well, if that were to be reported. And maybe that's a result of political pressure, and certainly we're starting from a much higher spending base, and we have much more room to, in theory, to reduce the rate of growth, potentially drastically without hurting quality and equity. But I think, the experience of all these European countries where they haven't chosen to limit to GDP plus zero, they go at sort of GDP plus something, and we're talking about maybe median wage plus zero or median wage plus something. It's not clear to me that the plus zero is, at least in the long term, the best choice. And I guess helping us have some discussion of that, I think, would be helpful.
So Rick, when you talk about add-ons, are you talking about blending?
No, I think the first state on the list did PGSP plus 0.5. I'm talking about the plus 0.5.
Add-on. Okay, so just
But you are thinking about a sustained add-on, right?
Maybe one that tapers over time.
Okay.
Probably more likely one that tapers over time.
Okay.
I mean, in part, it's also, and I asked the earlier question about, do any of the other states have the enforcement powers that California does? And it sounds like they don't. I mean, Oregon can assess financial penalties, but not clear how big. This is we have a very big hammer on the every extra dollar has to be repaid. And, there's a question, and I don't know how to answer it, and probably none of us know how to answer it, but maybe some discussion would be helpful. How quickly can the healthcare ecosystem change the trajectory that they're on? And I don't, maybe they can change it really quickly. And we haven't looked at numbers yet. I mean, my kind of rough sense is that median wage might be 2.5 points below the historic rate of healthcare spending growth. And if that's the case, 2.5 points is a pretty big change to make.
And well below commercial market spending growth.
Yeah, more than that below commercial. And some way of thinking about how big a change and how quickly, and whether some kind of tapered sort of add-on would make sense.
Mm-hmm.
As well as just this relatively minor point of an aging add-on, which maybe wouldn't taper, maybe that's permanent.
Michael, this was presented at the advisory committee, correct?
Yes.
Were there other population measures that were introduced or suggested by that group?
Shal, do you have them at hand? If not, I can pull up my notes.
Yeah, I don't think we got any concrete suggestions, but I would turn to Dr. Pan.
So, again, trying not to jump the gun here. So the advisory committee in hearing this discussion, they sort of lean toward median wage income, right? Want to do median, not average, and so that most of the comments were in support of that direction. And then in terms of, someone did mention, I think, about disabilities. I think population, there was a little bit of, that in terms of different population measures. So someone did mention, is there a way to look at, percentage of people with disabilities, et cetera? Otherwise, I don't recall other.
There's one other. Hector Flores, who was actually here earlier, had suggested the percentage of people living in poverty.
Oh, yeah, that's right.
I'm not really sure how to link that to spending, but that was a suggestion that he made.
Right, yeah, on the demographic side of things. I guess that's a demographic/economic measure.
Yeah.
Right. And one could argue that California, with its higher cost of living, how you define poverty. Do you use the federal poverty level? Do you use there's been other measures developed to measure who's in poverty in California that's a bit different than federal poverty level.
Michael, in the states that have already set measures, set targets, have some experience in them, from the data you presented here, it looks like virtually all of them end up at somewhere around 5%.
Below.
Below, right.
Yeah, yeah, they end up in the 2s and 3s, or they did, because we haven't had a new state set targets for a few years.
I see. So 2 to 3%.
Yeah, well, I would say 2 to high 3s, so not 3.0, but between 3.5 and 4.
Yeah, the spending and the target, got it.
And I guess the related question is, they set those targets what was the actual performance? Did people meet the target? They shot past the target, et cetera. So in other words, how realistic was the target? Or let's see, we've heard a lot that the targets help decrease the rate of spend, but we haven't heard so much that people actually hit the target and they didn't exceed the target. So, so
the experience we have right now, I'll summarize it much as it is. So Massachusetts, for the first 7 or 8 years, on average, met their target. Some years above, some below. But the last couple of years, they've exceeded their target, which has caused some alarm within the state. And so they're talking about what additional measures they need to take. The other states don't have as long a track record. Remember, it takes 2 years to get results. And then throw COVID and what that did to spending patterns. So it's a little more difficult to assess. The next 2 states that have the most experience are Rhode Island and Delaware. Rhode Island, even accounting for the dip and the jump from COVID, has performed pretty well relative to their target, very close to their target. Delaware not.
So not meaning exceeding it.
Exceeding it.
Right. Yeah. So.
And I'd say the other states just
not enough experience.
They just don't have enough experience.
Okay. All right.
And is there a clear link to performance against targets and affordability?
It's a great question. So how do we assess that? You know, I think that the measurement of total medical expense is certainly an indicator, but it's not an outcome measure of what was the out-of-pocket spending, because there are other factors that influence it, such as decisions on benefit designs by employers, right? Which is, out of the control, certainly, of this effort. We would like to think that if we slow spending, then the trend in benefit designs will not be towards ever-growing deductibles and co-insurance, but we don't control that. I don't have a good answer to that, Elizabeth, in terms of the direct experience of consumers. But it's the right question, and it's the ultimate outcome measure.
Exactly.
So I guess and again, you probably don't have the answer, so that's not entirely hypothetical, but I don't know if someone to look it up is that is potentially one of the responses of a plan or insurance company to actually increase as a way to try to, quote, decrease spend. That's what we hear, right? Oh, I need to decrease spending, so I'm going to increase the amount. We need to have people have more skin in the game, right? So that means, was there any shift in that direction?
So in all these target programs measure allowed spending, so they're including the consumer out-of-pocket spend. That being said, we know that when the out-of-pocket obligation gets to be very large, which it is for most Americans right now, that people stop accessing care.
Yeah. Richard?
Thank you. To Elizabeth's question, and this is returning to a much earlier discussion about baseline report, but something I meant to raise but did not then. It would be important to provide information about employer and employee payments towards premiums. I mean, thinking about affordability, what employees experience most directly about affordability is how much is coming out of my paycheck for the premium. It's also how much do I pay for co-payments and deductibles. And economists, of course, would say that the employer portion is really coming out of employees' compensation in the long run in any case. But still that division between employer and employee, I mean, the economists will swear it's coming out of employees' compensation, but most immediately what we all feel is what we're paying in premium. And I know that that would not come from the data sources that we're regulatorily allowed to compel insurers to provide, but again, either the data that's collected from the Kaiser Family Foundation and the employer survey, the CHCF, and the data from the employer portion of the medical expenditure panel survey could be used to put that into the baseline report. And I think that would be important to have.
Yeah, and I would add, Rick, that these would be important measures for assessing the ultimate impact of the strategy.
This is just anecdotal, but there is a big shift, at least among my members, to stop sort of increasing employee cost sharing because the research is now showing that it's actually a deterrent.
Deterring utilization.
It was a trend for about, well, too long, but it's not happening anymore.
Yeah. Michael, you have one more slide?
Actually, I just want to pause and make sure that there are no other suggestions that you all want to make, because we are going to prepare for the next meeting to bring you data. And if there are any other measures for which you would like us to do some research, now's the moment.
Elizabeth?
Sorry. I don't know how this fits, but the new Consolidated Appropriation Act regulations require self-insured employers to confirm and demonstrate that rate increases are related to utilization. And I think that that should somehow be factored into sort of what we're looking at, because they now have an obligation to the Department of Labor to demonstrate that. So there will be, I think that could be a lever of interest and worth exploring. I don't know exactly how this fits.
David?
One other question also. It seems that most of the states have used projected economic performance over historic. That's been the, I think, the consensus more in that direction. Is there a reason why they went in that direction?
Because it's easier, frankly. Because otherwise you have this issue of volatility and what time period do you pick? And which recession do you include, exclude, which economic expansion? And so I think that's primarily the reason why they've done it, because if you use forecasts, it gives you a point figure and you don't have to figure out how to deal with historical. I'm not recommending one or the other, that's my sense.
Richard, do you want to go?
Yeah, I guess the challenge with forecasting is, and you really should cross-check it with what really happened, right? Because the problem is that it's, of course, the forecast looks great and you make it look pretty and the lines are smoother and so forth. But I mean, we're dealing with reality here, at least we should be. And so whatever forecasting mechanism we use, if that's what we're going to base it on, should be cross-checked with what really happened. Obviously, you take some time to look back, but to see how good that forecast really is. And and by the way, talk about state budget, you talk about rolling out 5 years, but there's a reason we have a May revise, because even between January and May, there's significant changes that happen in the economy. So we can't even project in January what will happen in May that accurately. And so again, I think, the challenge of the forecast is false precision, right? So it's nice and neat, but, that false precision versus looking back, and we'll have recessions and we will have things that happen. And so, we got to figure out how to incorporate that into that, because that will happen in the future. There's, at least so far, I don't think the Fed's figured out how to eliminate recessions.
Yeah, so I mean, the forecast will be wrong on a year-by-year basis. The forecast is intended to estimate what it will average out to be over time. So we'll share with you what does the historical rate look like and what's the forecast look like, so you can judge that. We're going to present you with a series of questions at the next meeting and ask you to weigh in. Do we use forecast? Do we use historical? Which indicators? Do we weight them? Do we have an add-on? All these things that we've discussed, we're going to ask you to start to work your way through. Okay, you asked me to advance.
Please.
I shall do so. Okay, Michelle?
So in terms of next steps, as Michael mentioned, next month we'll be reviewing historic trends in spending for the commercial Medi-Cal and Medicare markets where data is available. And then we'll also share historic and forecasted data on growth rates for economic and population-based indicators. So more to come on this next month. And then in terms of the advisory committee, I do want to turn to CJ Howard to present some of the feedback we received yesterday. You heard some of it just now, but we just really want to make sure we capture it all.
Michelle, before we go there, in terms of this conversation that we've been having about what might be happening to rates and costs while we're starting to set these targets, are we going to get a chance to also look at the market consolidations that are also occurring in a very dramatic fashion during this period of time, which is also driving up costs? How are we looking at that particular phenomenon?
Yeah, with respect to market consolidation, the CMIR program, which you'll hear about in the next agenda item, it is going to start receiving its first set of notices on January 1st. It'll be too early to tell because the CMIRs have not been performed in terms of kind of transactions going forward. But in terms of consolidation to date, there's plenty of research, as you're aware, in kind of the markets that are consolidated, you know, the differences between Northern and Southern California and so on. Yeah, that is a consideration in terms of, you know, how do we control costs growth, and then also sector targets, you know, that could be a more targeted way to address certain markets where costs and affordability are more problematic.
Could we also consider other industries? Like there's a housing affordability index and they look at income, debts, and financial assets. I mean, there are other industries or sectors that look at affordability.
And if I could just add on, you know, I appreciate the immense amount of work that you're carrying out to implement this the transaction review process, but I'd really ask, because with the deadline coming, I think it's April 1st for both transaction review and market failure review. It would be helpful to hear your thinking as to how we're going to approach the market failure. I'd be especially interested in the two things that Dr. Hernandez just mentioned, and I would put on the table, given everything that we've heard, that Monterey needs to be an early focus of those powers as well.
Rick, you good?
Sort of, Sandra, with your opening of something else that would be good to know. Something else that would be good to know. You know, Elizabeth mentioned the 20% premium increases. CalPERS has announced increases. I think UC has now announced increase for next year. I've seen consulting, reports from consulting companies that I'm sure other people have seen talking about 6.5%. That's nationwide, not California specific. It would be certainly useful as we look at the data on the historic performance of the 6 indicators that Michael went through, or at least 5 of them. The aging one seems kind of not really a separate indicator. To also look at historic healthcare spending, and as well as projected healthcare spending. That should be simple, maybe less simple, but to the extent that we've got any information about 2024 premium increases, that might be helpful context as we think about add-ons or not in the future.
falls into the category of what else could you measure? Many things is the answer to that question. Okay, can we hear the feedback from the advisory committee, please?
Hello again. So actually, I think that most of this has been covered, but happy to make sure that it's stated clearly. So the advisory committee really did seem to coalesce quite quickly around the consumer-centric measures, those being median family income or wages, with a careful caveat of erring or biasing towards medians over averages, which I think also was reflected in the discussion here today. One member did note that there are certain types of spending, in particular pharmacy spending, that currently outpaces inflation, and just something to be mindful of or aware of. And then as far as other measures or indicators, the consideration for disability status or the federal poverty level is, I think Michael Bailey referenced. So I don't know, Senator Pan, if you had other sort of takeaways from that discussion.
No, I think we covered it. Thank you.
Okay, I think we'd like to now open it up for general comment.
We will now recognize members of the public for comment on this agenda item. Looking to those attending virtually, please raise your hand.
Anybody in the
I'm seeing a hand. Okay, great. Travis West, please go ahead. You're unmuted.
Hi, yeah, this is Travis West with California Nurses Association. We just wanted to say that we support median wage or median family income as a indicator for setting the target spending rate, with, as was just mentioned, a focus on median rather than on an average. We believe this would be or go a long ways towards ensuring that the rate is actually reflecting affordability. So just wanted to get that point across to the board. Thank you.
Thank you. Moving to the individuals in the room, please step to the podium.
Good afternoon. Thank you. I'm Laura Lucia. I'm the director of the healthcare program at the UC Berkeley Labor Center. And I wanted to share that on Friday, we released a policy brief related to the spending target and the economic indicators called What Can We Afford? Aligning OCA spending targets with Californians' ability to afford increases. And we looked at 5 different economic indicators, which were very similar to the ones just presented, with the exception that we looked at median wages instead of average. And the report includes historic data for the different economic indicators, and we also looked at projected projections where available. I just wanted to reinforce a point that's been made very well already about using medians over averages for household income and wages. Just to add some data to that, in California, the median wage growth at the 95th percentile that's those earning about $120 an hour, so very high wage. Between 2014 and 2021, the wage for that group grew by 55%, whereas at the median, those earning about $25 an hour, it grew 12%. So it's just really important to capture what's happening for the typical worker and keep out the high end, which doesn't have bearing for the typical worker. And in my few seconds remaining, I know you've heard a lot of testimony from workers from Monterey County about the high healthcare costs there. Today, the Labor Center released a blog post that I can share in public comment, highlighting some of their stories and also providing data that really reinforces what you've been hearing about the problem of high healthcare prices there. Thank you.
Thank you. Moving back virtually, we have a hand raised. Bianca, you are unmuted. Please go ahead.
Hi there. Thank you so much. I just want to flag that we have a couple folks that have called in that are unsure how to raise their hand. I can put their mobile number in the chat for you to be on the lookout to unmute their phone. I would like to start by sharing remarks on behalf of Catherine Mitchell, a small business owner in our network who had to hop off a couple minutes ago. Thank you for allowing me to share my story today to discuss, as it's imperative to address the high cost of healthcare for small businesses in the state. My name is Catherine Mitchell. I'm the owner of Mitchell's Transport LLC, a transportation company in Oakland, California. I learned of this opportunity to speak through Small Business Majority. When I embarked on my entrepreneurial journey, the weight of healthcare expenses was of paramount concern. The issue resonates deeply with many entrepreneurs, particularly women who often rely on employer-sponsored health coverage, especially before and after starting a family, when healthcare expenses can become substantial. Consequently, many aspiring entrepreneurs retain their job-based health insurance, effectively juggling full-time employment and running their business. The escalating healthcare costs have undeniably shaped my decisions regarding hiring and expanding my business. They significantly influence our ability to provide competitive wages and comprehensive benefit packages to our valued employees. We're committed to striking a delicate equilibrium between delivering top-notch healthcare and upholding a sustainable business model. As conscientious employers, we often go above and beyond. I'm not alone in facing these challenges. On a personal note, the burgeoning healthcare costs have left an indelible impact on my life, often choosing between personal expenditures and essential medical procedures or treatments. Occasionally, these unforeseen costs place considerable strain on my finances. I've had to navigate this challenging terrain firsthand, and it's amplified my understanding of the urgent need for transformative change. I truly believe that the state of California has an opportunity to act on this issue on behalf of small businesses and our hardworking employees, particularly Californians who are low to moderate income. Thank you. I also have remarks on behalf of John Burgess, another small business owner who had to hop off. My name is John Burgess. I'm the owner of Burgess Brothers, a food services and catering business in Sacramento. I learned of this opportunity through Small Business Majority. Unfortunately, I know firsthand how challenging it is to afford and offer employer-sponsored health coverage, and I know how common this issue is among other small business owners. When I started Burgess Brothers, I didn't consider offering healthcare coverage because of the massive financial obstacles that came along with offering it. Unfortunately, the high cost of healthcare has impacted my hiring process by reducing the number and caliber of candidates I can hire. Healthcare is a desirable benefit, and when a small business like mine does not offer it, we are left with tier 3 employees who are not always the best fit for the business. Offering healthcare is simply unobtainable for many small business owners like me. For those that do offer health coverage, they struggle to afford it. The high cost of healthcare is holding too many small business owners back, and it's hurting our businesses, our employees, and our state's economy. You have an important opportunity to make healthcare affordable for small business owners like myself. I urge you to consider these challenges on behalf of all California workers. Thank you for the opportunity to share both of these remarks today. And I would like to flag that the number 213-268-2802 would like to make a comment. Thank you.
Thank you. Moving back to the individuals in the room. And for the individuals dialing in, if you press *5 on the line, it should raise your hand. Going back to the individual in the room at the podium.
Beth Capel for Health Access California. So like many others, we think affordability, the ability of consumers to afford to access care in terms of cost sharing, deductibles, and copays, the share of premium, and the premium that the employer pays all matter in terms of affordability. The third area we would suggest, and CHCF has as best we can tell, the richest inventory on this, is the impacts of lack of affordability, medical debt and other lack of impacts. We would encourage that you monitor that, along with the spending targets, that you monitor out-of-pocket spending, premium and share of premium, as well as the impacts of medical debt. And we are also, so like others, our preference is for median wage or median income. And we think that's an important way to measure whether we're actually succeeding in making healthcare more affordable. With respect to the increasing costs, fortunately, the small group market in California is largely state regulated and largely regulated by the Department of Managed Healthcare. So we can see the increasing premiums and decreasing actuarial value in the reports from the Department of Managed Healthcare. I would note that if I'm reading a slide that we had yesterday correctly, you start off with a baseline report using the 2022 and 2023 data. So that would mean that the 2024 increases that are now rolling in would show up as a matter of comparison in subsequent reports. I think we're all going to have to learn to manage this multi-year rolling, where's the target, where's the data. But I think to the extent that those 20 to 25% increases, I know, 20 to 25% increases are occurring, you'll be able to track it. Thank you.
Looking back virtually, Adam, we see your hand raised. You have been unmuted. Please go ahead.
Thank you. Adam Zarin with the Leukemia and Lymphoma Society. Our mission is to cure blood cancers. Appreciate the conversation today, and we really encourage you guys to continue to consider how high healthcare costs directly impact patients. Costs, especially out-of-pocket costs, drive adverse outcomes for patients' health and financial stability. For example, on average, a blood cancer patient can incur $156,000 in total medical spending in 12 months following diagnosis, and their average out-of-pocket spending was $3,877. Several studies show that cancer patients dig into or even deplete savings to pay for their care. Many go into debt because of their care, and are 2.7 times more likely to file for bankruptcy. And these problems are even worse for non-white individuals. In fact, some of our patients have shared the great lengths that they will go to get access to life-saving treatments. Some have traveled abroad and smuggled their cancer drugs back into the United States in order to save $60,000 in copay expenses. But worst of all, some will skip doses or abandon treatment altogether. And research shows that 70% of commercially insured patients abandon newly prescribed medications when they had to pay more than $250 for treatment. So a statewide spending target must incorporate the patient experience, their ability to access care, and their ability to pay. Smuggling drugs or abandoning treatment are unacceptable outcomes, and we can create better results if spending targets really reflect the actual costs for patients and control those impacts in the future. Thank you.
Thank you. Continuing public comment, alternating to the individuals in the room, please step to the podium. And as a reminder to our virtual attendees, it is pressing *5 to raise your hand. We understand there might be technical difficulties on that. We are working on that right now.
Hi, Ben Johnson from the California Hospital Association. Appreciate the robust and, for many of us, marathon discussions of these issues over the last couple of days. Just want to emphasize what CHA believes to be really the multi-pronged and pluralistic mission of the Office of Healthcare Affordability, I think phrased well in the statute to promote improved affordability while maintaining quality and access. So we just ask the office and board in these discussions to really focus on what we think has to be the underlying goal of improving the cost effectiveness and value proposition of the healthcare delivery system. And we do have questions about whether or not the office can achieve these goals by simply picking a spending target based on an economic indicator that is not tied closely to the underlying drivers of healthcare spending. So we do encourage a surgical approach, identifying areas where spending can be reduced without negative trade-offs in terms of access, quality, and equity, and setting the targets with these considerations squarely in mind. We wrote a comment letter to the board, highlighted what we thought to be an excellent study identifying some of the drivers of the inefficiencies in the healthcare market, and which CHCF actually adapted to the context of California, and it provides significant room for thought on discrete areas where inefficiencies can be addressed. Some additional considerations would just give in 25 seconds are, population aging is a major factor. Projections show the share of the population in California over 65 is going to double with special growth over the over 85 population. The after effects of the pandemic have providers reeling. Many are in severe financial distress and facing huge growth in their underlying costs. And then finally, the impacts of new or outstanding state mandates, such as may come come through if a minimum wage increase for healthcare workers go through. So look forward to having these discussions in the future, and so much to consider. Thank you.
Thank you. Looking back virtually, seeing no hands raised at this time, we understand that there may be individuals dialing in who are unable to raise their hands, and we are not seeing those phone numbers showing up on our list at this time. I do have another virtual attendee raising their hand. Bianca, please go ahead. Bianca, you're unmuted on our end. You might have to unmute on your end.
Thanks so much. I am submitting comments on behalf of Mary Sue Milliken, who's listening in and trying to make comments via telephone. My name is Mary Sue Milliken. I'm the owner of Socolo, a restaurant in Santa Monica. I learned of this opportunity to speak to you through Small Business Majority. I've been offering health coverage to my employees since 1981, but it has been very challenging. I've been fortunate to never have had any major health conditions that weren't covered by a health insurance plan, but some individuals on my team have had those problems for years. Over the years. Even though access to health insurance coverage is a priority for employees, many members of my staff opt out of our coverage because they can't afford the high costs. My employees must cover 50% of premiums. They're simply not seeing enough change in the cost to allow them to take advantage of this benefit. Although I wish I could cover more of the premiums, it is just too costly. This has also impacted my hiring process in a number of ways. I'm forced to balance out pride and priorities when hiring new employees. Many prospective and qualified employees are looking for robust employer-sponsored health coverage. Again, I would love to cover 100% of the cost, but then I would not be able to raise wages to a level that is necessary in this economic climate. If I raise my prices, then customers may choose to dine elsewhere, creating a domino effect. I'm not alone in these challenges. Small Business Majority's research has found that roughly 9 in 10 small business owners rank the cost of healthcare as a top issue facing their small business. The state of California has an opportunity to act on behalf of small business owners and our hardworking employees. Thank you to the board, and I hope this board will create targets that will make affordable healthcare a reality for California's small business community. Thank you.
Thank you. Looking back to individuals in the room, seeing none, going back virtually. Looks like Deonda, you have your hand raised. You're unmuted. Please go ahead. And you need to unmute on your end also. You're unmuted on our end.
Hello, I'm sorry about that. My name is Dee Guerrero. I'm the SEAU 521 chapter president for the employees of Monterey County. I'm here to discuss seeking help in finding affordable and obtainable health care for our county workers and members of our community. Quality healthcare services should be effective, safe, and affordable, and should improve the life of the entire community by providing health services with sustainable premiums to everyone. As of today, many providers have had to drop patients as these health insurance companies are not willing to pay in Monterey County. It's time we start demanding better decisions and direction from our government, providers, and the community of workers willing to help make these changes. We are talking about our lives, our futures, and sometimes it's the difference between paying rent, buying food, and keeping your loved ones alive. Let's stop these conglomerates from killing us and making a profit and start working together to provide for the needs of this community. Thank you for your time.
Thank you. Looking for individuals in the room, seeing none. Looking to individuals online, noting we have about 6 to 8 attendees. I'm seeing no hands raised at this time. I understand we may be having technical difficulties. There is an option to submit public comment on the email address noted in the agenda, oka@ca.gov, hki.ca.gov. At this time, that concludes public comment on this agenda item. We will have another public comment, general public comment period at the end of the meeting. Thank you.
Okay, thank you for all of the public comment, and look forward to hearing from folks who couldn't call in. Okay, Michelle, I'll give it to you on the cost and market impact review.
Thank you, Chair. As we mentioned at the beginning of the meeting, Assistant Deputy Director Sheila Tatayan is not available, but Assistant Chief Counsel in the Healthcare Compliance Branch, Brian Kearns, will be discussing this agenda item.
Hey everyone, I'm Brian Kearns, Assistant Chief Counsel with the Compliance Branch. So today I'm going to talk about the current status of our regulation package and largely focus on the comments we received yesterday during the advisory committee meeting. Since we're kind of running out of time here, the first two slides I'll just generally summarize. The first slide just identifies our emergency rulemaking authority that has been granted to OCA by the legislature. The second slide talks about the difference between an emergency versus regular rulemaking. We have the emergency rulemaking power, which is identified on the left. What that power gives us is the ability to basically pass regulations on an expedited timeline versus a regular rulemaking, which is a much longer timeline. What you see on the left is what we hope to do in late October, early November. But before then, we have put out our regulations for public comment, and we have also received comments from the advisory committee, which I will now go into. So we had a written comment period that ended August 31st. During the August timeline on the 15th, we had a regulation workshop. So during our written comment period, we got about 20 comment letters. Those letters came from unions, physician groups, health plans, hospital systems, private equity, consumer advocacy groups, and medical, hospital, and nursing associations. So a lot of the comments that we've been getting from the workshop and the written comments, and as I'll discuss from the advisory committee, there's a decent amount of overlap. So what I'll describe here in this slide and the following two slides are what was the recurring themes from the workshop and the written comments. So one of the biggest areas of that received comments was our thresholds and circumstances for filing. And as part of how our regulations are structured, you have to meet a certain revenue threshold of 25 million, and you have to file and you have to complete a certain type of transaction. If you're a healthcare entity with a revenue of 10 million or above, and you're involved in a transaction with a 25 million healthcare entity, you also have to file a notice. So we received a variety of comments that either suggested that we needed to have much higher revenue thresholds or we needed to have much lower revenue thresholds. Another hot issue were management services organizations. Our current regulations include management services organizations as a healthcare entity. We received a variety of comments during the written comment period why we should remove them. Other comments supported our inclusion of the MSOs. Another hot issue during the written comment period was timing. So we got some comments asking for clarity on when they need to file a notice. Currently, we're working on language to sort of clarify that, but a lot of what the commenters expressed to us is when do they need to file the notice? Does it when the transaction closes, 90 days before the transaction closing? So they asked for clarity on that front. We received a variety of comments that express concern about the length of time that it'll take to review the notices and to conduct a CMIR. And multiple commenters during the workshop and during the written comment period asked for an expedited review process. We also have the regulations identify a variety of criteria that we'll consider when deciding to do a cost and market impact review or CMIR, and those factors to be considered when that review is taking place. So we got a variety of comments suggesting that the criteria was too broad and that we needed to more narrowly define it. There were some factors that were perhaps unclear to some commenters, so they asked for clarification. As part of our the information that we'll be asking from healthcare entities, we're asking them to sort of talk about impacts to particular services pre and post transaction. And we had a variety of comments asking us to include how the transaction will impact the full range of reproductive and sexual health services, including contraception, abortion, and LGBTQ plus health services. So we got similar comments regarding behavioral health services. A variety of commenters asked us to more strongly consider impacts to the labor market, and some suggested that we include the labor market as a factor, as a threshold, actually, for conducting a CMIR. Some commenters expressed concerns over how the regulations were structured to handle confidential documents. Other commenters supported the ability to submit confidential documents, and then others were more concerned that we should get assurances from the submitters that the documents are indeed confidential, and commenters suggested that we verify that the healthcare entities have always maintained these documents as confidential. Other commenters wanted us to look at the source of funding for the transaction. So where are the funds coming from one healthcare entity, and how are they being used in the transaction? A few commenters wanted us to look at how the transaction was beneficial, to have us consider the benefits of the transaction. And if that was going to be something that we would consider, what evidence are the submitters relying on to conclude that the transaction is beneficial? We got other comments that requested more involvement from the public during the MCN review, the material change notice review process, as well as the CMIR process. We got comments during the advisory committee meeting and during the written comment period asking for some kind of cap on the fees that potentially could be incurred by the submitters. Our regulations are structured, they don't include a fee now, but the way they're structured is that OCA would be entitled to reimbursement of reasonable fees that we incur in reviewing each transaction. So there were some new issues that were raised during the written comment period. We had a variety of commenters look at our definition of transaction and look at our definition of affiliates. And regarding transactions, we had comments that were supportive of broadening the definition as it currently exists. And then we had others that wanted it to be narrower. Same with affiliates. We have affiliates in the definition of our healthcare entity, and that to implicate potential other entities that may be involved in the transaction. We had new comments that somewhat aligned on previous comments regarding labor and staffing, but they provided more detail on how we should consider effects to labor and staffing pre and post transaction. There was several comments expressed concerns over the level of detail that we're asking for each material change notice. And we had support and opposition to our definitions of materiality and control. A few commenters were concerned that our thresholds as designed would implicate transactions that occurred during the ordinary course of business. And a few made comments to that effect regarding our definitions of materiality. We received comments regarding why the regulation should address OCA's ability to do a CMIR to investigate market failures. Our current enabling statute allows OCA to do a cost and market impact review to investigate market failures at the HCI director's discretion. So we received comments to the effect of asking us to more clearly address that in our regulations. We received supporting comments and opposing comments about a few areas in our regulations that will look back. So our threshold, one of our thresholds looks at whether the entities involved in the transaction have completed similar transactions in the previous 10 years. And when we're asking for information from the healthcare entities, and those entities have been involved in in transactions for the previous 10 years, we're asking for information about those transactions. So we got comments supporting and opposing those regulations. So again, a lot of what we heard, we got a lot of really helpful feedback from the advisory committee yesterday. There was a semi-prolonged discussion about how our thresholds implicate a large number of transactions, and then OCA will be inundated with a review of transactions. And we also got other comments supporting the regulations as written, and even suggesting that they should be broadened to include more transactions. And I think the statement more or less was, we don't know what we don't know. So starting off with broad factors will allow us to more fully understand the transactions that are occurring. There was a discussion regarding how our thresholds and definitions implicate health technology. So currently, transactions involving health technology may be the health entities that are involved in those transactions may be required to file a notice, depending on the different thresholds that may be implicated. So there was discussions about the pros and cons of that approach, and a prolonged discussion about how electronic health record transactions would be implicated in our thresholds. Additional discussions on the inclusion of MSOs, both support and opposition to that approach. There was also discussions on the costs to the healthcare entities. As I previously discussed, the regulations are designed to enable OCA to recoup reasonable expenses incurred with the review of a material change notice as well as a CMIR. So the advisory committee members discussed how it could potentially be expensive to do a CMIR and the potential burdens that would be placed on those entities that were involved in the transaction. We also received additional comments regarding the regulations, how they address impacts to the workforce, both pre and post transaction, both post transactions. Some members suggested reviewing healthcare entities' past labor violations when conducting a cost and market impact review. So if there's been a history of labor violations, there may be more likely market concentration was one of the comments that was made. And that was largely the high-level overview of what was voiced during the advisory committee meeting. I'm going to skip ahead one slide and then pass it over to Dr. Pan to offer additional input. So this is just an overview of where we're at now and where we're going to be in January. So we are revising the regulations, and we expect to post a revised version in mid-October. The next board meeting, we will be updating the board on the areas which we revised the text. The end of October, we are intending to post the advance notice of the emergency rulemaking online, which essentially starts the emergency rulemaking process. We will then submit the package to the Office of Administrative Law. And then it is our hope that the emergency rulemaking regulations will become effective in November or December. We will also finalize our e-filing portal around that time, which healthcare entities can use to give us all the information that will be required under the regulations. And then in January 1st, we will start accepting filings. So Dr. Pan, if you'd like to offer some additional input on the advisory committee.
Yeah, no, thank you so very much. And again, I appreciate your description of the advisory committee discussion. I think that people did raise concerns about sort of the breadth of the filings and also exactly what we're trying to get at for some of them. So I think perhaps one of the ones you point out is the EHR, right? So an EHR purchase for a system could easily exceed the threshold, and so the purpose of filing for the EHR is because we think someone purchasing an EHR, upgrading the EHR would then cause them to consolidate or something. So I mean, I think so I think being able to draw a direct line as to why we want to know about that transaction, because there were certainly comments people said, well, we just don't know what we don't know, and we just want to sweep up all this information. But I think, I think some people raised some issues about, okay, well, what is the purpose of making us file for this? I think there, so I think it's, so I think there are probably some, it's helpful to at least say what's the purpose of requiring certain types of filings for certain types of purchases, right? So I think most people agree, like mergers and acquisitions and so forth, that's, that's consolidation, right? Purchasing an EHR is not necessarily consolidation unless you can somehow define what kind of purchase. And I think similar comments about MSOs as well, is that, there's some MSOs that are basically just, they're just doing administrative work, and do you really want, versus there may be perhaps, it's possible you could have some that evolve into, but again, saying what's the purpose, because one have to recognize the cost is not simply what the reimbursement is to this office for the CMIR. It's also the cost of filling out all the paperwork and filing it, and then having to respond and so forth. There's administrative cost, right? So that's cost. That's funding those are resources taken away from patient, from clinical, et cetera. I mean, those resources have to come from somewhere. So I think we need to acknowledge that. I think what was also asked was that I think in the past, actually, in one of our minutes, we talked about how many filings can we handle, right? So what's the bandwidth of the agency, right? So I think we've frequently talked about, well, we have to staff up, et cetera, but so the projection is 100 filings per year that they think will be based on the threshold of 25 million. I guess the question is that with all the other things that could trigger a filing, because it's not just simply has to be over 25 million, how many filings are there, and are we going to handle that? I think there's some back and forth about the confidentiality, and in some senses, I guess the question would be is, okay, you make everyone do all these filings, then they're all sitting at HCI. Do we have the staff to actually analyze any of that? So there's a cost to making people do all the filings, just the file. Is there going to be enough people to analyze? So are we really going to get at that bigger picture, right? So it's we don't know what we don't know. Oh, well, we actually have the capacity to find out. And of course, that data will get older and older the longer you don't look at it, right? So I think it really does come down to, what is it that we're trying to get at? I would make note that UC made a, there is an exception for clinical research and GME, but they also mentioned that there's affiliations that are related to other health professional education. Does that make sense to include that or not? So I think certainly there were many comments about specific things, PHR perhaps being the bigger one, but also others like, what is the purpose, right? Is this really leading to consolidation? And so while there's certainly, neologists, many people says, well, we don't know, we should just sweep up a lot of stuff. I think other people have said, well, why is it that you need this? Because there is it takes effort to compile that information. And if there's a clear purpose, I think, okay, well, but if there isn't a clear purpose, then we're just overburdening not only the entities that, and causing delays because you have to wait and hear back, but also is it just going to sit in a filing cabinet somewhere, or are we really going to have the staff to look at this, not just to review the individual, but if this is really about, we don't know what's happening, well, someone's got to take a look at all of them and say, well, what is the pattern and so forth? Do we really have the capacity to do that? And especially if you're sweeping up a lot of things that there's a clear idea about what it's going to lead to, is that really going to be, is that really going to be fruitful, right, in terms of that? So I think those are some of the issues that were raised. They talked about things like contract renewals or debt and refinancing. Is that included? And there may be some circumstances where maybe it does make sense, but so when they talk ordinary transaction in business, so for example, if you already have a contract, now it's expired, you want to renew the contract, you now have to go through this whole CMIR type thing. So and so exactly which ones really needed to or not. And then I think certainly on the confidentiality side, obviously if the documents are confidential, then no one else is going to be able to analyze it out of the agency. I think certainly there's a point people made that if you're going to say it's confidential, you better have treated it as confidential. Otherwise, if it's already public, that doesn't make sense. But certainly confidentiality, there were concerns about financial information and confidentiality in terms of that issue, but also saying that, if it's confidential, then unless it hasn't been kept confidential, we can't look at this bigger picture issue. So there's quite a few notes, but I tried to summarize some of that.
I think we got it all. So that was it. That was my presentation. Any comments or questions?
Any comments from the board? Questions, Rick?
Well, a request first. We were provided, I think, 3 of the comment letters, but it would be useful to see the other 17. And I looked on the website, but I wasn't smart enough to find them.
We actually just posted the ones that were directed to the board, but we can certainly make the entire letters available, and they'll be part of our rulemaking as well.
Thank you. And then a question. So, I saw in the comment letters, and Dr. Penn mentioned again, and you brought up, people were concerned that replacement of electronic health record would require a filing. Is that a correct statement?
It depends on who's involved in the transaction and the size of the transaction. Some commenters said that this is going to implicate a lot of those types of transactions, but if you have a $25 million healthcare entity, a healthcare entity with $25 million in revenue, and they complete a transaction that is $25 million or more, then yes, it would be implicated.
And I mean, I am sympathetic to the argument that why should that be? And I wonder what your response would be.
Yeah, I think our intent with including healthcare technology was just that the size of some of these transactions and the impacts on healthcare pricing would be something that we wanted the public to know more about. We saw them as material transactions that had high potential to influence pricing. I don't know, Vishal, did you have anything further to add on that?
Yeah, we're continuing to assess that issue. As Brian mentioned earlier, some of the commentators said things that are happening in the ordinary course of business that may not be our intent to capture those types of activities. We're still assessing the issue, but and that may be part of our revision process in terms of what we identify as possible areas of revision.
I mean, I think that, as a number of people said, I mean, focusing on market failure is not necessarily even new transactions. Again, we've heard about Monterey quite eloquently many, many times. Focusing on market failures and on consolidation, to me, makes sense as a first foray. And, as the capabilities of the office increase, potentially broadening would make sense as well. But I would kind of start with the highest priorities, or suggest thinking about starting with the highest priorities rather than trying to sweep in everything at once.
Other comments from the board? Thank you for your remarks.
Thank you.
We'll now move to public comment. As this is the last agenda item, we will accept public comment on this agenda item and also general public comment at this time. Looking to individuals attending virtually, please raise your hand. Seeing none at this time. Inviting individuals in the room to step to the podium.
Hello again, Ben Johnson from the California Hospital Association. Appreciate the additional opportunity to speak on these regulations. Had many opportunities so far already. I should have this speech down. So we do have substantive concerns with the draft regulations as we've shared, and we would just emphasize that the legislation states that the office's responsibility is really to review transactions likely to have a significant impact on the market. And as drafted, we do believe the current rule would be contrary to this intent. If finalized as proposed, we do believe the office would be inundated with a large number of transactions, including EMR purchases, a contract with a health plan to be an in-network provider, a contract to have a new radiology group serve on call or as an associated entity, or even when you combine with the serial transaction requirement where there is no materiality threshold, that all individual letters of agreement for care of out-of-network patients involving the same health plan would have to be filed regardless of the financial value of this transaction. So in addition to concerns around transactions that do occur over the ordinary course of business, we do have concerns that the process would take too long, minimum of 250 days if going through the full process. There are no assurances for healthcare entities that the fees charged would be reasonable, that the regulations fall short of providing clear criteria for which transactions will fall under a full review, ask for too much information at the outset of when a notice is filed, do not properly allow for the benefits of a transaction to be considered, and then don't guarantee the confidentiality of certain pieces of sensitive information. So we have detailed comment letter, both to the board as well as through the regulatory process. Happy to share that as well, and appreciate the engagement on this issue.
Thank you. Looking back virtually, Liam, we see your hand raised. Give us one moment to unmute you. All right, Liam, go ahead. And Liam, you'll need to unmute on your end also. We can't hear you yet.
Thank you. Can you hear me?
Yes.
Great. Thank you so much. My name is Liam McLaughlin. I'm an organizer with SEIU 521. We represent the city and county workers all throughout the Central Coast. I specifically work and represent workers in Monterey County, San Benito County, and Santa Cruz County. In all three of these counties, the number one issue for our public servants, these are social workers, these are, folks who work at the landfill, these are our planners, or city and county planners, these are folks in our permit office, right? They're the people who kind of make government run and administer public services to the public every single day. Their number one issue is healthcare and the cost of healthcare. And of course, this also affects the counties they serve, right? The county boards are constantly trying to find room in the budget to pay their workers health care, and have found less and less ways to do that, unfortunately, which leaves these workers suffering. And when it comes to the contract negotiation times, we are sacrificing wages, we're sacrificing other workplace conditions just to secure somewhat decent healthcare rates, right, for these workers. It's totally untenable. It's resulting in massive retention and recruitment issues. Folks come to work as a social worker in Monterey County, and they can't afford any sort of wage increase they get through negotiations is offset by increasing healthcare costs. So I'm just calling in to advocate on behalf of these workers, and to call on your office and everyone who's working there, just to do what you can on behalf everyone in terms of healthcare, but in particular your public servants who are making the government run, and the counties that are employing them. So thanks for your time. I appreciate what you guys are doing here.
Thank you. Moving back to individuals in the room, please. Both. Thank you for asking. Please step forward.
Ladies and gentlemen, the board, staff, Steve McDougall with the CFT, a union of educator professionals and classified professionals. And just want to, since I'm a history teacher, quality health care was for the privileged before the Great Depression and World War II. And if it wasn't for Kaiser, who found a workaround, the federal laws and regulations to avoid strikes and slowdowns and keep wages down, to find an alternative to compensation, and that was health care for their employees. When they were building reservoirs, pouring concrete, building Liberty ships to support the war in the Pacific and abroad. And over time, they traded in their cement trucks and their shipyards for stethoscopes and scalpels. And this is true. But that all being said, over time, it brings us to today that it's seemingly no surprise in the grand experiment that we're all participating in here over time in this country, that is the working class who found an alternative to salaries and wages, healthcare, that it is subsidizing healthcare not only for those who can't, but also for those who have. And here we are. And in Monterey County, we've got one major network at odds with one provider, and our siblings from Local 521 are directly impacted by that. A couple of them have spoken here today. Furthermore, this working class labor leader is a leader of a board, a JPA, who on next Thursday has an agonizing decision of how much to raise our rates by and or cut benefits by. And that is next Thursday. That's not in 2027 or 2030. And it's just never going to stop until something is done. That's my homework over the next week and a half. Thank you.
Thank you. Looking back virtually, seeing hands raised. Elena, you're next. You should be unmuted. Please unmute on your end.
Hi, good evening. Elena Santamaria, Senior Policy Advisor at Next Gen Policy. We're a nonprofit, statewide nonprofit based in Sacramento with our goal to uplift the youth voice. And on healthcare costs are too high. We've surveyed a number of youth, and among the top issues for them, among student debt, it's medical costs. And so we're asking that the office adopt spending targets that are based on real wages of young people and not skewed on to match the state's GDP or wages for the most affluent. The office has the opportunity to slow spending growth and ensure the needs of everyday Californians to actually afford care is made it a priority. Appreciate the work that you all are doing, and appreciate the time. Thank you so much.
Thank you. Looking back in the room, going to the individual at the podium.
Hello, my name is Justice Swatry. I'm a policy fellow with the California Hospital Association. Thank you for this meeting today. It's very interesting. I think the work that you guys are doing is very, very good. And my comment is not on your primary objective of reducing healthcare costs, but actually on your secondary objective on maintaining quality. Within the meeting, I have a couple of questions on how do you guys define quality, because quality is very broad within healthcare as well. And within the other states that you guys are modeling this, modeling targets of, what were the relationship between healthcare costs and how patients experience quality as well too. I think that's very important to consider. Thank you.
Thank you. Looking back virtually, Alicia, you should be unmuted. Please go ahead, unmute on your end. Alicia, we can't hear you yet. You may need to unmute on your end.
Hello, am I unmuted now?
Yes, you are. Go ahead.
Oh, okay, thank you. Again, good afternoon, everyone. Thank you for the opportunity to speak. I am proud to serve Monterey County as a social worker in Family Children Services, and I have been here for some plus years. What I will say, I am also proud to serve SEIU 521 as a Region VP, Region 2 VP, just a shop steward, just to serve my brothers and sisters, not just in 521, but just working people in general. And I'm here just to echo comments that have already been made in regard to the rising costs of healthcare and the rising costs that it is affecting our members by. I just always share my personal story of my mom who worked as a CNA home health care aide for her career, and who was unfortunately diagnosed with multiple myeloma. I heard someone speak of blood cancers, which is a blood cancer, in 2003. My mom, of course, was not in a union and was receiving wages that were not going to be enough to cover the cost of health care to fight her cancer. But she had health care benefits that allowed her to receive the best treatment that I believe she could, before again helping her fight a very good fight and to gain her wings. So I just implore, I make a plea that we all should be able to afford health care. We should not have to sacrifice our just our basic needs in order to remain healthy or to fight the fight that we might find ourselves in when we are hit by these catastrophic diseases. So again, I'm just here to implore on the behalf of working people in general, the middle class, again, who the budget is
2
balanced off
minutes.
of our hard work. Thank you.
Thank you. Going back to the room, the individual at the podium, please go ahead.
Katie Bessler, Monterey County, Salinas Valley Federation of Teachers. I stand here so proudly because Steve McDougall and I drove up from Monterey County, and after this meeting, we'll drive back. We are committed to fighting this fight, but I am proud of all my sisters and brothers who have been on this meeting to express their concerns with Monterey County. As was alluded to earlier, Monterey County is just the start of what is going to happen with healthcare. But we are so fortunate that this board is taking this work so seriously. I want to acknowledge the questions that were asked today because I think we're all starting to poke at the real issue, which is, will this body be able to work on affordable healthcare when it's already run away so quickly? But we are committed to being partners, and we just want everyone to know that we need help because we can't afford health care, and it is a right. Thank you so much for your afternoon work.
Thank you. Looking back virtually, Debbie, you are unmuted. Please go ahead.
You can hear me?
Debbie, yes, we can hear you now. Thank you.
Okay, great. Good afternoon. Thank you very much, everyone, for your time. Appreciate the work of this body and what you do for our communities. My name is Deborah Narvaez. I'm the Chief of Staff with SEIU 521 and resident in Salinas, California. Monterey County is a rural community that is in need of affordable, accessible, and quality healthcare. Monterey County has many barriers when it comes to cost and finding physicians in a very rural county. 59% of our population in Monterey County right now is a Latino population made up of hospitality workers, childcare workers, agricultural workers, public and private sector workers who are now struggling to find health care in with this market concentration that exists in this county and the non-competitive prices that working families can't afford in this $400+ billion healthcare industry in California. And it's time that we do something about it for the residents of Monterey County who feed the world with our agricultural work. Thousands of workers right now are competing with each other just to find new physicians and new primary care with the loss of the contract of Anthem Blue Cross with Salinas Valley. And having to wait 6 to 8 months to find a new physician because that's how long it's going to take to get in and be seen is not acceptable for anyone. For those that are don't have access to healthcare, that is going to be even longer wait. So we're asking for your assistance to please look into this and address this market concentration that is hurting working families and hurting our community. Thank you.
Thank you. Looking back to the individual in the room, please go ahead.
Beth Capel, Health Access California. Let me start with the Monterey disaster. Um, You have the authority to do reviews of market failure. I think, as others have said, Monterey seems to count in that category. Unfortunately, there's a drafting defect in the regulations that appears to prevent that, and we have offered language to correct that. With respect to the other comments, it is not a surprise that those who would be subject to the transaction reviews have a different perspective than those who care about the cost that consumers are paying and purchasers. Our perspective is that a threshold of $3 million is what the Attorney General currently uses for nonprofit health facility transactions. And the definitions in the law, although not identical to the language for the Attorney General, have substantial similarities. We would also encourage the office to assure that it has sufficient time and resources to review what in many cases will be multi-billion-dollar transactions. Some will be small, and we've heard a lot about those today, but some will be multi-billion-dollar transactions, and that will take time and staff resources, and you have ample authority for consulting resources, which you will need. We have sought that information be public if it's not otherwise confidential. We've also sought additional opportunities for public comment. And however much fun the board meetings have been, if there's a major transaction and there's not an opportunity for a public meeting or a public hearing on a significant transaction, people will show up here, I guarantee it. They've found you, they're not going back. With respect to benefits, they should be measurable and enforceable. There should be evidence. If people are going to make promises, we should know whether they're real. Thank you.
Thank you. Continuing public comment, looks like we have one hand raised virtually. Travis, please go ahead.
Hi, yeah, again, this is Travis West with California Nurses Association, and thanks again for the opportunity to speak. To begin with, I wanted to speak about the inclusion of health technology as a covered transaction. We support that continuing inclusion as a covered transaction. There's a lot of talk about how we don't know failures in the market right now, and it's good to gather a lot of information to make sure that we, know what we don't know. And in addition to that, I wanted to make the point that technology issues can impact patient care and access directly. For instance, patient acuity tools that nurses use can have a direct impact on the type and kind of care provided. There's also been a lot of research recently on algorithmic bias and how that can relate to care denials and issues related to access as well. And then in terms of, electronic health records, of which a lot was made today, coding is directly involved with medical loss ratios, and all of this is information that ties directly into affordability and information that, frankly, OCA should be concerned with. So we would urge the continued inclusion of health technologies transactions in the draft standard. Additionally, I wanted to emphasize that market failure is part of the review process. And sort of related to that, it's come to our attention that potentially this could include the closure or could include review of all hospital closures. We think this is something that we should look into in rulemaking and in the future going forward. And we would encourage OCA to see if the review of hospital closures generally is something that would be covered, outside of specific transactions. In addition to that, I wanted to emphasize points we've made in our written comments regarding the continued inclusion of managed service organizations, as healthcare entities subject to the material change notice and CMIR requirements. Even though their decision making is based on financial risk and not based on clinical judgment. Just one moment, please. They function as gatekeepers and should be regulated as well. And we have additional comments in our written comments. So again, thank you so much for the opportunity to comment today.
Thank you. Looking back to the individuals in the room. Seeing none, we understand that there was technical difficulty for some individuals to make comments during the public comment period today. We encourage those individuals to submit their written public comments to oca@hcai.ca.gov. The email address is on the screen right now. It is also in the publicly posted agenda. That concludes public comment.
And that concludes our agenda for the day, unless the board has any other matters. If not, please.
Such a brief question. I mean, if something gets filed to CMIR, we're doing a cost and market review. So, for example, if someone referred a piece of technology like an EHR, is this office actually going to review the technology itself, or simply its market? It's supposed to be a cost and market review. So just for clarification as to what the scope of any filing would involve, what kind of analysis would be involved by this office.
Yeah, that's correct. As you know, that the statute is focused on the impact of costs, healthcare costs, and market consolidation.
I appreciate the clarification because I think it's important we know what the purpose, what the filing will result in. And of course, there are many things that should be filed to be examined for that reason, but there's other concerns. This may not be the appropriate mechanism to address that. But again, thank you for the clarification.
Great. There's nothing else. We're adjourned. Thank you.